Okay. Chalo bachcho. Good afternoon again. Hopefully I'm audible and the screen is visible as well. Once you are here, let me know so then we can begin. Okay, great. Chalo. Now let's talk about a very important topic from your endocrinal surgery, and that will be breast. Okay. So now once I begin with breast, bachcho, first thing that you have to understand, what are breasts? Breasts are also known as the mammary glands. They are made up of two kinds of tissue. One will be the glandular tissue which is present inside them. Okay, and the second is actually fat. Yes. So breast is actually made up of two things. One is definitely the glandular tissue. Second is nothing else but the fat which is present inside them. Okay. Now we know definitely the breast or the mammary glands which are there. They are what? They are nothing but a modified sweat gland or a sebaceous gland. The screen will come in a while. Just a minute. So please tell me, are they sweat glands or sebaceous glands? So you have to remember that these breast is nothing but the modified sweat glands itself. Okay? These are nothing else but the modified sweat glands itself that you have to understand. Okay? So that's the important thing. Chalo. So we were discussing about breast itself. So you have to remember it is nothing but a modified sweat gland. Important is so I was talking about breast, Bacho. For example, this breast is present on the chest wall, right? And we know that the chest wall is made up of which muscle? So your chest wall is made up of your pectoralis muscle. For example, consider this is your pectoralis muscle. Okay, for example, this is your pectoralis muscle. Okay, and then definitely on the pectoralis muscle you have this fascia. We know the covering of a muscle is known as a fascia. This fascia is what is called as your pectoralis fascia. This fascia will be your pectoralis fascia, and on that pectoralis fascia definitely then you will have your breast. Okay, on that pectoralis fascia definitely you are going to have your breast. Okay, this is what is the structure of a breast that you have to remember. Okay, this is what is the structure of a breast that you have to remember. Now in the breast, definitely in the center, this erectile tissue which is present, this erectile tissue which is present is known as the nipple. Okay, so this is the nipple which is the erectile tissue of the breast, and then definitely there will be a darkly pigmented area around the nipple. This darkly pigmented area around the nipple is called as areola. Okay, important is that. Now we know that this breast which is there, which it is made up of two things. Definitely, as I've told you, it is made up of, one important will be the glandular tissue. Okay, one is definitely the glandular tissue which makes it up, and second is definitely what? The fat. Okay, glandular tissue and fat will be present in the breast. Important is the glandular tissue will be of two types. What? So you have to remember, definitely we will have a lot of sacs in the breast, and these sacs are known as alveoli. These sacs which are there, they are called as alveoli. Then these sacs which are there, bacho, they are going to continue into lactiferous ducts, and all these lactiferous ducts which are there, they are going to open up at the level of the nipple. Okay, all these lactiferous ducts which are there, they are going to open up at the level of nipple. Important is these alveoli which are there, they are responsible for milk production. The milk production which is done, that is done by these alveoli or the alveolar sacs, and this milk is drained at the level of nipple with the help of these lactiferous duct. Each breast will contain around 15 to 20 lactiferous ducts which are going to open at the level of the nipple itself. ठीक है, तो ये याद रखना. Glandular tissue also has two components to it. One is the alveoli which produces the milk. Second are the lactiferous ducts which actually carries the milk. ठीक है, that's important. Now जैसे जैसे age बढ़ती है, what is going to happen? So please remember, as the age of the patient increases, the glandular tissue is going to decrease and the fat is going to increase in the breast. Yes, so you have to remember, as the age of the patient is going to increase, the amount of glandular tissue in the breast is going to decrease and the amount of fat in the breast is going to increase. Therefore, patients who are in the reproductive age group will have amount of glandular tissue in the breast, but the patients who are in the menopausal age group, definitely they will have more amount of fat tissue in their breast. That you have to be aware of. Got it? So definitely this is the breast. How does it how it looks like? These are nothing but your ribs. Definitely on the ribs, definitely we know we have the chest muscles, and the main chest muscle which is there is your pectoralis minor and the pectoralis major muscle. Then this pectoralis minor and major, it's covered with this fascia around here, and this fascia is nothing but your pectoralis fascia. And above this pectoralis fascia, can you see you have this breast? This breast contains a lot of yellow color tissue. That yellow color tissue is nothing else but your fat tissue itself or the adipose tissue. And then definitely you have all of these glandular tissue. Glandular tissue is made up of two things. One is these sacs which are responsible for milk production, known as your alveoli, and then second are these lactiferous ducts which are going to carry the milk till the level of nipple. So these 15 to 20 lactiferous ducts, they are going to open at the level of the nipple. Then this darkly pigmented area around the nipple is known as the areola, that you have to remember. In this areola, bachcho, we will have some small sebaceous glands. Yes, in this areola we do have some small sebaceous glands. ये sebaceous glands की hypertrophy हो जाती है during pregnancy or lactation. Yes, there is hypertrophy of these sebaceous glands during pregnancy or lactation, and then they become more prominent. ये जो prominent sebaceous glands है pregnancy or lactation में due to hypertrophy, these prominent ones are called as Montgomery tubercles. ठीक है, these will be called as Montgomery tubercles usually. ठीक है, important is you have to remember that one alveolar sac along with the duct is known as the lobule usually, and multiple lobules together is known as the lobe. Okay? So you have to remember that one alveolar sac with a duct is known as a lobule, and definitely one and many alveolar sacs together is known as a lobe. Okay? So that's the basic funda that you have to be aware of. And important is inside the breast to support the breast tissue. Yes, inside the breast to support the breast tissue. Can you see these, what I'm highlighting right now? These which are there, bacho, these are nothing but your suspensory ligaments. These suspensory ligaments are actually attached to the skin. Yes, these suspensory ligaments are actually attached to the skin. For example, if I draw it like this, there will be something like this. See, if this is the breast tissue, we will have, just a minute. For example, if this is the breast tissue, bacho, definitely we will have these kind of these suspensory ligaments. Can you see these suspensory ligaments which are there? They are actually attached to the skin and to the pectoralis fascia. These suspensory ligaments are known as suspensory ligaments of Cooper. In ligaments को क्या बोला जाता है बच्चे? These are known as suspensory ligaments of Cooper. And what is their role? They are over there inside the breast just to support the breast tissue. Otherwise, what will happen? The breasts are going to hang down. Therefore, if we want to actually keep the breast hanging properly, we want these suspensory ligaments of Cooper inside the breast. They start from the pectoralis fascia and they go till the skin of the breast. So that has to be remembered. Now, if I talk about the breast anatomy, so you have to remember breast, as I've told you, it is a modified sweat gland, that has to be remembered. Yes, it is a modified sweat gland. We know that breast is also known as a mammary gland. We know that breast can also be referred to as the mammary gland, that has to be remembered. Okay. Next important is extent. We have to remember that breast कितने से कितने level तक होती है. So please remember, breast vertically which is there, the vertical extension of the breast is, it starts from the second rib and it extends till the fifth rib. Okay, it starts from the second rib and it extends till the sixth rib usually. That is the normal vertical extension of the breast. Horizontal extension अगर देखें तो So you have to remember it starts from the lateral border of the sternum. It starts from the border of the sternum and it goes usually to the anterior axillary line. It goes from sternum till the anterior axillary line. But in some patients, definitely the breast can be larger in size also, which starts from the clavicle and it can reach up to the 8th rib as well. Yes, if the breast is very large or huge in size, then it can start from the clavicle and it can go till the 8th rib also. Okay? So that's the important thing. As I've told you, in some people, okay, in some people you have to remember it can start from clavicle till the 8th rib. It can start from clavicle and it can extend up to the 8th rib. That can be the huge extension of your breast as well. Vertically, as I've told you, normally it is between 2nd to the 6th rib. Horizontally, it is between sternum to the anterior axillary line. Now, we have seen already that breast is present on which fascia? Breast is actually present on the pectoralis fascia. Okay, so you have to remember this breast which is there, it is present on the pectoralis fascia. It is actually the fascia of your pectoralis muscle. That has to be remembered. Next important, there is a breast tissue which goes into the axilla. Yes, there will be some amount of breast tissue which goes into the axilla. So whenever I'll draw breast from anterior side, it will be something like this. It will be something like this, right? This extra breast tissue which is there, bacho, this breast tissue which can go inside the axilla, this is what is called as the axillary tail of Spence. इसको क्या बोलते हैं? ऐसा लग रहा है ना पूंछ हो breast की. So therefore this is what is called as the axillary tail of Spence. Please remember the breast tissue which goes inside the axilla, bache, that is known as the axillary tail of Spence. That is known as the axillary tail of Spence. No issues with this, anybody? That has to be remembered. This is what is your axillary tail of Spence, which is nothing but the breast tissue inside the axilla. It is nothing but the breast tissue inside the axilla. This has been a previous year question. Okay? Tail of Spence is nothing but the breast tissue which goes inside the axilla. Next important that you have to be aware of is the suspensory ligaments of Cooper. As I've already told you, that suspensory ligaments of Cooper which are there, they are over there present inside the breast to just support the breast tissue, and they will be more in which part of the breast, upper or lower? Definitely more support we need in the lower part of the breast. Therefore more amount of suspensory ligaments will be present in the lower part of the breast. Okay? Suspensory ligaments of Cooper, it supports the breast tissue which is more in the lower half of the breast, which is more in the lower half of the breast. That has to be remembered. Next is lactiferous ducts. As I've already told you, lactiferous ducts का काम होता है to carry the milk till the nipple. So these lactiferous ducts which are there, they are 15 to 20 in each breast and they are going to open at the level of the nipple. Next is what is the functional unit of a breast that you have to be aware of. If I talk about the functional unit of a breast, it is TDLU. What is TDLU? Terminal duct lobular unit. What do I mean by this? So you have to remember it is nothing but one lobe and one alveolar sac together. Sorry, one duct and one alveolar sac or one lobule together. This is what is called as the terminal duct lobular unit, TDLU. That is what is the functional unit of a breast. Jaise functional unit of a brain is a neuron, for a kidney it is a nephron. Just like that, the functional unit of the breast tissue is a terminal duct lobular unit. It is known as a terminal duct lobular unit. Okay, no issues with this, anybody? That has to be remembered. Next important, if I talk about what are Montgomery's tubercles, I've already told you that in the areola, that means the black pigmented part around the nipple which is there, bache, in that areola definitely we have these sebaceous glands. But these sebaceous glands will undergo hypertrophy during pregnancy or during lactation and they become more prominent. These prominent sebaceous glands or hypertrophied sebaceous glands are what are called as the Montgomery tubercles. Okay, no issues with this, anybody? So please remember, first of all, what is areola? As I've told you, areola is nothing but the darkly pigmented area. Areola is nothing but the darkly pigmented area around nipple. Darkly pigmented area around the nipple is what is called as the areola. And what are the Montgomery tubercles then? So Montgomery tubercles, now you can write down definitely. These are nothing but the hypertrophied sebaceous glands. These are nothing but the hypertrophied sebaceous glands. These are hypertrophied sebaceous glands in areola during pregnancy or lactation. These are hypertrophied sebaceous glands in the areola during pregnancy and lactation. No issues with this, anybody? That has to be remembered. Okay, that has to be remembered. कोई दिक्कत नहीं है इसमें, प्लीज रिमेंबर दिस. ओके, चलो. Now next important is, if I talk about the lymphatic drainage of the breast, that was about the Montgomery tubercles. Now if I talk about the lymphatic drainage of the breast bacho, in the lymphatic drainage of the breast, you have to remember that breast mainly drains into two groups of lymph nodes. Yes, breast usually drains into, all organs will have some lymphatic drainage. Yes, वैसे ही breast का भी अपना खुद का एक lymphatic drainage होता है. It is going to drain into some lymph nodes. And which lymph nodes it is going to drain into? So we have to remember that breast is going to drain mainly into two groups of lymph node. 90% of the lymph which is there, 90% lymphatic drainage of breast occurs in the axillary group of lymph node. जो lymph node यहाँ होता है axilla में, okay, 90% of the lymphatic drainage of breast occurs usually in the axillary group of lymph nodes. 10% will occur in the internal mammary lymph nodes. Yes, 10% will occur in internal mammary lymph nodes. So let's write down that. So as I've told you, 90% of the lymphatic drainage is going to happen in the axillary lymph nodes. It is going to happen in the axillary lymph nodes, whereas only 10% of the lymphatic drainage, it is going to happen in the internal mammary lymph nodes. Only 10% is going to happen in the internal mammary lymph nodes. No issues with this, anybody? Hopefully this is clear to everyone. Okay, so that has to be remembered. Now if I talk about the axillary group of lymph nodes, बच्चों, this axillary lymph nodes जो होते हैं, definitely you have to remember anatomically they are divided into 5 groups. Okay, anatomically they are divided into 5 groups. Definitely one will be the apical group, second will be the anterior group, third will be the posterior group, fourth will be the central group, and fifth will be the lateral group. Okay, so please remember these axillary lymph nodes which are there. These axillary lymph nodes, anatomically they are divided into 5 groups. They are the anterior, posterior, central, lateral, and apical group. Next important is, surgically we have to remember them for sure. Surgically they are actually divided into 3 levels. Yes, there are 3 levels of the axillary group of lymph nodes surgically. Reason is, definitely in a case of breast cancer, when we have to remove these axillary group of lymph nodes, we actually have to understand which group of lymph nodes are involved and which group of lymph nodes have to be removed. Therefore, we have divided them surgically into 3 groups, or 3 levels rather, I would say. That is level 1, 2 and 3. And you can easily remember it as L, B and M. Okay, you can easily remember it as L, B, M. What do I mean by this? So, level 1 lymph nodes which are there, they are lateral to the pectoralis minor muscle. Level 2 lymph nodes which are there, they are behind to the pectoralis minor muscle. And level 3 lymph nodes which are there, they are medial to the pectoralis minor muscle. Yes, so please remember the levels of the axillary group of lymph nodes are decided in relation to the pectoralis minor muscle. In relation to the pectoralis minor, not the major, in relation to the pectoralis minor muscle. If the lymph nodes are lateral to the pectoralis minor, that is level 1 axillary lymph node. If they are behind the pectoralis minor, they are the level 2 axillary lymph node, and if they are medial to the pectoralis minor, they are level 3 axillary lymph node. For example, if this is a pectoralis muscle, take a pectoralis minor, these group of lymph nodes which are present medially, okay, and this one are the present ones which are present laterally, and ye behind the pectoralis minor. Important is, these will be level 1, these will be level 2, these will be level 3 lymph nodes. Okay, so that is how the arrangement usually you have to remember. That is how it is the arrangement of the axillary group of lymph nodes. No issues with this, anybody? That is the basic understanding. Now, what are the Rotter's lymph nodes? This has been a previous year one-liner question that has been asked in your examination. The Rotter's lymph nodes which are there, bacho, they are interpectoral lymph nodes. Okay, now Rotter's lymph nodes which are there, they are known as interpectoral lymph nodes. Interpectoral, by the name itself it is evident. Interpectoral, that means between two pectorals, right? And which two pectorals? Between the pectoralis minor and between the pectoralis major. Can anybody tell me, as these lymph nodes are present between the pectoralis minor and major, please tell me, okay, can anybody tell me that these lymph nodes are present between the pectoralis minor and major? So these will be which levels of lymph nodes? Level 1, 2 or 3? Please tell me that. These are interpectoral lymph nodes. They are present between the pectoralis major. They are present between the pectoralis major and minor muscle. They are present between the pectoralis major and the pectoralis minor muscle. Okay, that has to be remembered. See, axillary group of lymph nodes which are there, bacho, they are divided anatomically into 5 groups, that is anterior, posterior, central, lateral and apical. More important for us is to understand the surgical levels of these lymph nodes. Please remember, according to the levels, these surgically are divided into 3 levels depending on the relation of these lymph nodes with the pectoralis minor muscle. If they are lateral to the pectoralis minor, they are level 1 lymph nodes. If they are medial to the pectoralis minor, they are level 3 lymph nodes. And if they are behind, exactly behind the pectoralis minor, they are the level 2 lymph nodes. But so you have to remember that the the rotus lymph nodes which are there, the interpectoral lymph node, they are usually the level 2 lymph nodes. They are usually the level 2 lymph node because they will lie behind the pectoralis minor, right? As they will lie behind the pectoralis minor, that is the reason why these rotus lymph nodes will be called as level 2 lymph nodes. This is the important question that has to be remembered. Okay? So that is important to be remembered. Next important is definitely, if I talk about this question now, okay, that was about your lymph nodes. So please remember, in a case of breast cancer, the main lymph nodes which will be dissected, or the main lymph nodes which will be removed, will be a axillary group of lymph nodes. That has to be understood. Now question states, a lady presents to you with a breast lump. Lump is nothing but a mass, for example. Okay, so there is nothing but a breast lump in the patient. What will be the best approach for assessment of this patient? What will be the best approach for assessment of the patient? So in this you have to understand, bache, in this you have to understand definitely, in this patient, the best approach for assessment is nothing but examination. So any patient who comes to you with a breast lump, okay, always the best method of assessment is called as a triple assessment. What do I mean by triple assessment? We are actually going to examine 3 things in the patient. What are those? Let's see that. So definitely the best method of assessment, any patient coming to us with a breast lump, is triple assessment. What are the 3 things in a case of triple assessment? Let's see those now. So if I talk about the triple assessment, the first one you have to understand, is the history taking and clinical examination. Okay, so first important thing is definitely you have to remember it is history taking. Okay, so you have to take proper history in the patient, because the patient might have a family history of some breast cancer, the patient might have some family history of another condition, okay, another benign breast diseases, or maybe the patient herself the patient might herself have a breast cancer in the past. Okay, anything can be there. Therefore a proper history taking should be done in the patient, and along with that definitely clinical examination should be done. So the first step which is there in a case of triple assessment is definitely history taking plus clinical examination. The first step is definitely history taking plus clinical examination. That has to be understood. Then the next one that you have to be aware of is the radiological investigation. Yes, once you have done history taking in the patient and once you have clinically examined the breast lump of the patient, after that definitely you have to go for a radiological investigation. You have to send the patient for some radiological investigation, and that radiological investigations will be what? So you have to remember, if the patient is usually less than 40 years of age, that means the patient is young and the patient is in the reproductive age group. In this definitely we know her breast will contain more amount of glandular tissue, and if there is more amount of glandular tissue, x-ray like a mammography for example will not be very clear. Okay, that is the reason why here we have to send the patient for an ultrasound. If the young patient comes to us with a breast lump, definitely then for radiological investigation we are going to send the patient for an ultrasound. Whereas if a patient more than 40 years of age comes to us, if a patient who is more than 40 years of age is going to come to us, in that patient definitely we can send that particular patient for a mammography. कोई दिक्कत नहीं है बच्चे, that has to be remembered. ठीक है, तो please remember this. If I talk about the third investigations that we do usually in this patient, once we have done the radiological investigation, उसका ultrasound या mammography का report आ गया. Okay, once the ultrasound or mammography report comes, then definitely we are going to take up the patient for the histopathological examination, HPE. HPE is nothing but histopathological examination. That means we are going to take some amount of tissue from this, or we are going to take some amount of cells or some amount of tissue from this breast lump, and then we are going to send this to the pathology lab. Okay, where the patient definitely, where the pathologist definitely is going to check these cells or these tissue under the microscopy, and he is going to tell us whether the patient is actually having a benign mass or the patient is having a malignant mass. Okay, so that has to be confirmed as well with the histopathological examination. So for histopathological examination you have to remember, either we can go for a FNAC, that is a fine needle aspiration cytology. Okay, fine needle aspiration cytology. So by the name itself you can see fine needle is generally used. Okay, we aspirate what? cells, okay, and cytology. Cytology is nothing but study of cells. So yaad rakhna, fine needle aspiration cytology can be done. Over there only cells will be studied, cells will be examined, not the tissue as a whole. Okay, but the other investigation is known as a true cut biopsy, which is actually considered as the investigation of choice or the single best investigation in examination of a breast lump. Okay, because nothing is better than a biopsy, because we will get directly what? We will directly get what? A tissue, and on that tissue we will be able to differentiate whether it is a benign lesion or it is a malignant lesion. Okay, we will be able to tell whether it is a carcinoma in situ or it is an invasive carcinoma. What are those? I'll talk about them. So true cut biopsy is definitely considered as the investigation of choice or the single best investigation for confirmation of a breast cancer. No issues with this, anybody? So that is what is the triple assessment, as you know now. Triple assessment, first thing is definitely history taking plus clinical examination. Second is radiological investigations. Less than 40, it is ultrasound. More than 40, it is mammography. And third important is the histopathological examination. In that, we can either do a FNAC, that is a fine needle aspiration cytology, or a true cut biopsy. Now definitely history taking, to all of us are quite aware. How do we take it? Definitely you have to ask about the present complaints of the patient. Then you have to ask about the history of the present complaints. That means, for example, if the patient is having breast mass, you have to ask whether the breast mass is painful or is it painless, how much is the size, okay, so all of that. Then you have to ask the history, like when did it start, okay, how did it grow, it has grown slowly or it has grown very rapidly, okay, everything about the history of the present complaints as well. Then you have to ask about the past history of the patient as well, okay, about the past history and even the family history of the patient. You also have to ask her personal history, that means any addiction history, smoking, alcohol, anything like that, okay, the number of children that she has definitely, okay, so everything that you have to ask. And once you're done with this history taking, then you will go for a clinical examination. So for clinical examination of a breast lump, bacho, definitely there are various methods which are there. There is a vertical strike method, when you will go from top, you will bottom, then again come to the top, again till the bottom. This is called as a vertical strike method. Then second is the horizontal strike method, when you will go from lateral to the medial, then again come back lateral to medial. This is what is called as actually the horizontal strike method. But the best method for examination of a breast lump is neither horizontal strike nor vertical strike. It is what? Dial clock method. What do I mean by dial clock method? You will start from you will start palpating the breast lump from the center. Yeah, you will hold the breast lump, you will start palpating it from the center, and then you will go outwards. Then you will start palpating outwards. Then you have to see how much is the size of the breast lump. Is it movable or not? Definitely. Is it fixed or is it movable? And important is whether the breast lump which is there, it is having circular margins or it is having some irregular kind of margins, definitely. Okay, what is the texture of the breast lump, whether it is a very firm breast lump or it is definitely a soft breast lump, everything you have to study about that. So important is what is the best method of clinical examination, that they are going to ask you. So please remember, the best method of clinical examination for a breast lump is going to be the dial clock method. It is going to be the dial clock method. No issues with this, anybody? It is going to be the dial clock method. Okay, so yaad rakhna ye अच्छे से. Important is now, if I talk about the imaging, once we are done with the clinical examination, we are going to go for imaging, that is radiological investigations. And definitely, if I talk about the imaging or the radiological investigations already, the first and the most commonly used imaging technique, the first and the most commonly used imaging technique that you have to remember, please remember, it is nothing else but mammography. Now what is graphy? Graphy is nothing but a picture. Mammo means mammary gland or your breast. So a picture of your breast is what is called as mammography in simple terms. So what is mammography? It is actually an X-ray of the breast itself. Yes, mammography is nothing but an X-ray of the breast, that you have to remember. Okay, so mammography, bache, it is nothing but the X-ray of the breast, that you have to remember. Important is this mammography which is there, it is taken in two views. We have to take the mammography in two views. First is definitely the craniocaudal view, and second is the MLO, that is the mediolateral oblique view. Now, what is done in both these views? Let's see that. For example, this is the mammography technique, how it is going to be performed. Can you see there are two paddles over here? These two paddles which are there, they're actually compressing the breast in the center, as one paddle is compressing it from above and the other paddle is compressing it from below. Why do we want to compress the breast? The reason is to actually get a proper imaging, okay, to actually get a proper imaging. Therefore we actually compress the breast and then we get a proper imaging. So you are as over here the paddles are compressing the breast from above and below. This is what is called as the craniocaudal view. This is what is known as the craniocaudal view. Okay, sar se leke pair tak, that is the craniocaudal view. Whereas if the breast is compressed from sideways, if the breast is compressed from the lateral and the medial side, this will be called as a mediolateral oblique view. This will be called as a mediolateral oblique view. This is how the picture is going to come. This will be the mammogram which you will get. Okay, this is what is the mammogram that you are going to get definitely. Can you see this is the craniocaudal view usually? Okay, this is the craniocaudal view of the mammogram. And this is the MLO, that is the mediolateral oblique view. Can you see in mediolateral oblique view, this area which is there, this area is also covered. This is the extra tissue which is covered in the mediolateral oblique view. That is nothing but the axillary tail of Spence. मैंने बोला था ना, the part of the breast which goes inside the axilla, known as the axillary tail of Spence, that is actually visualized with the help of the mediolateral oblique view itself. तो तुम्हें ये याद रखना है कि which one covers more area? Definitely the mediolateral oblique view covers more amount of area, and therefore if I compare both of them, craniocaudal and mediolateral oblique view, okay, both have its own importance, but ज़्यादा बेहतर कौन सा होगा? Definitely the mediolateral oblique view will be a better one. But whenever we do a mammogram, we have to take both the views. Yes, we have to take both the views, craniocaudal as well as MLO view. ठीक है? So mediolateral oblique view, as I've told you, it covers more area. Okay, it covers more area. Mainly it covers the axillary breast. Okay, it covers more area, and therefore it is a slightly better view. Therefore it is a slightly better view. No issues with this, anybody? That is important. Otherwise we take normally, अगर हम mammography करते, we take both the views in a patient. ठीक है? Important is if they ask you what is the best screening method. Now screening is done for what? First of all, I hope all of you are quite aware about the basic difference between a screening test and a diagnostic test. Screening test is done on the healthy population, patients who do not have any kind of signs and symptoms. Okay, but we want to diagnose a particular disease early in these people. That is when we are going to apply a screening test. But diagnostic test is done on whom? Diagnostic test is actually applied on the patients who are having the signs and symptoms, and we want to confirm our diagnosis for a particular disease or a condition. ठीक है? So please remember this, बच्चे. You have to remember that. स्क्रीनिंग टेस्ट, फॉर एग्जांपल सर्वाइकल कैंसर के बारे में देखते हैं. सर्वाइकल कैंसर में व्हाट इज द स्क्रीनिंग टेस्ट? ऑल ऑफ अस आर क्वाइट अवेयर, इट इज द पैप स्मीयर और द वाया दैट वी कैन डू इन अ केस ऑफ cervical cancer. But what is the investigation of choice? Is it the same? The diagnostic test or the investigation of choice, it is actually a colposcopic biopsy, right? So the same applies for here as well. Whenever a patient comes to us with complaints of a breast lump and we are suspecting a breast cancer, definitely, okay, in that condition the investigation of choice has to be a true cut biopsy, or rather the whole examination will be called as triple assessment. But when we are actually going to screen for breast cancer in the whole village population, पूरे गांव में पता लगाना है whether the females are having breast cancer or not. Okay, so in that condition we cannot do true cut biopsy or triple assessment in every person. Okay, so definitely these are normal females. We just want to check, we just want to screen if they are having any complaints or if they are having any risk of breast cancer. So in these females definitely we have to recommend what? Mammography in the patients. We have to recommend mammography. So you have to remember बेस्ट स्क्रीनिंग मेथड की अगर मैं बात करता हूं बच्चों, द बेस्ट स्क्रीनिंग मेथड विच इज देयर, इट इज मैमोग्राफी. रीजन इज मैमोग्राफी इज अ चीपर मेथड बिकॉज इट इज जस्ट एन एक्सरे. ओके, इट विल बी चीपर मेथड, इट विल बी इजीली अवेलेबल एज वेल. ठीक है, सो द बेस्ट स्क्रीनिंग मेथड विल बी अ मैमोग्राफी. ओके, इंपॉर्टेंट इज ओनली risk factor with mammography is what? You have to remember that mammography is nothing but X-ray. Therefore, there will be some radiation exposure. How much is the radiation exposure in a mammography? A radio question or a surgery question it can be. So, the radiation exposure after one mammography will be around 0.1 to 0.2 centigrade. बच्चे, ठीक है? It will be around 0.1 to 0.2 centigrade. Okay, that will be the amount of radiation exposure after one mammography. ठीक है? 0.1 to 0.2 centigrade. Next important that you have to remember is when should the screening start? Definitely every female. We know rather the most common cancer worldwide and the most common cancer in females worldwide is also breast cancer. As the incidence or as the number of cases of breast cancer are increasing so rapidly, it's better that we screen the females for breast cancer so that we can make a early diagnosis of breast cancer and we can start the treatment early so that the outcome or the prognosis of the patient is much better. ठीक है, इसीलिए you have to start screening for breast cancer in all the patients, okay, or all the females normally. And what is the timing to start it? So you have to remember the method to start it is definitely mammography, and this mammography should be done annually, and the start time for screening is definitely at 40 years of age. You have to start it at 40 years of age and it has to be started annually. That means हर साल you have to do mammography of the patient. ठीक है, so that has to be remembered. Next important thing that you have to remember, if it is a patient who's having a strong family history, if she is a patient who's having a strong family history, then in that patient definitely you should start the screening as early as possible, that is as early as 35 years of age. ठीक है, if she is having strong family history, what do I mean by that? For example, her mother was diagnosed with breast cancer or her real sister was diagnosed with breast cancer. ठीक है, that is a strong family history of breast cancer. In these patients, definitely the screening for breast cancer should start as early as 35 years of age, and the same technique can be used, that is mammography, because till 35 definitely the amount of glandular tissue in the breast would have been reduced. ठीक है, तो इतनी दिक्कत नहीं आती है 35 even. But if the patient is having a BRCA mutation, now what is BRCA? BRCA बच्चे is nothing but a gene definitely, and this BRCA gene mutation, it is associated with breast cancer. This BRCA1 or BRCA2 gene mutation, I'll talk about that, BRCA1, BRCA2, these gene mutations are associated with breast cancer in a patient. So you have to remember that if a patient is actually having this BRCA gene mutation herself, खुद को है उसमें BRCA mutation, या फिर she is having actually a family history, she is having a family history of this BRCA gene mutation, then in that condition you have to consider this female as a high risk female. Yes, you have to consider this female as a high risk female, and in these high risk females you have to start the screening very early. You have to start the screening as early as 25 years of age. In the high risk females who are having BRCA gene mutation either in themselves or in the family, you have to start the breast cancer screening as early as 25 years of age. And we know at 25 years of age there will be a lot of glandular tissue in the breast. So if there is a lot of glandular tissue in the breast, will the mammography picture be clear? No, the mammography picture will not be clear. Therefore, in a young patient, the screening method of choice should be ultrasound. Okay, in a young patient, the screening for breast cancer should be done with the help of an ultrasound or ultrasonography. Okay, USG. Important is if they ask you, bache, the screening test of choice. If they are going to ask you the screening test of choice for breast cancer patients in various conditions, you have to be aware of that. Now, if the female is less than 40 years of age, as I've told you, young females, more amount of glandular tissue in the breast, so the screening test of choice in this patient is going to be the ultrasound. The screening test of choice in this patient is going to be the ultrasound, that you have to remember. Next important is, a female is more than 40 years of age, definitely we should have a cheaper technique as well as a technique which can tell us a lot about the breast cancer, that is nothing else but mammography. So definitely if the female is more than 40 years of age, we can easily go for a mammography itself. Okay. Next important, if it is a pregnant female, definitely pregnant female matlab she might be a young female also. And second important, pregnancy mein radiation exposure is absolutely contraindicated. Usually X-ray is completely avoided during pregnancy. So if she is a pregnant female, we go for an X-ray or a mammography? No. So in a pregnant female, definitely the safe investigation which will be there will be again an ultrasound. Okay, again you have to go for an ultrasound in a pregnant female. Screening for breast cancer in a pregnant female is done with the help of an ultrasound. Next is a female with breast implant. For example, a patient was having some kind of breast implant, like usually the ones that we use commonly are the silicone gel breast implants. So if a female was having silicone gel breast implant and we are suspecting breast cancer in this patient, definitely the screening in a female with breast implant should be done with the help of an MRI. Okay, it will be done with the help of a MRI. Okay, and in higher risk females, we can better use MRI. Okay, in higher risk females, definitely we can better go for a MRI. So for example, as I told you, यहाँ पे young female है. Okay, so here definitely you can start with ultrasound. But if you feel that definitely I need a better technique which should be there, so therefore you have to shift off. Okay. So if you feel that you need a better technique in this patient, if you feel you need a better technique in the patient, you can start with an ultrasound, but a better technique will always be MRI in high risk female. Okay? A better technique will always be an MRI in a high risk female. No issues with this, anybody, bacho? That has to be remembered. Okay? That has to be remembered. ठीक है, तो ये याद रखना ये बात. डेफिनेटली इन अ हायर रिस्क फीमेल द स्क्रीनिंग टेस्ट ऑफ चॉइस इज गोइंग टू बी एमआरआई. नो इश्यूज विद दिस. ये क्वेश्चंस अच्छे से ध्यान रखना. दीज हैव बीन आस्क्ड कॉमनली. Female less than 40, it is always ultrasound. Female more than 40, always a mammography. Pregnant female, ultrasound again. Female with breast implants, MRI. And high risk female like BRCA gene mutation or a family history, again a MRI will be a better choice. ठीक है. Now if I talk about the mammography, if I do a mammography, we have spoken about the two views, the craniocaudal and the mediolateral oblique view. Now how are we going to identify a benign lesion or a malignant lesion on a mammography? This is important. There are a few things that you have to remember. But important is they might give you an image of mammography, but more important, they might mention the features of the image in the question itself. ठीक है, तो इसलिए याद रखना, it is very important because the mammography findings can easily tell you about whether it is a benign lesion or it is a malignant lesion. Important is this is a normal mammography. As you can see, this is nothing but a normal mammography. In this condition, can you see a lump which is there inside the breast? Yes. Okay, this lump which is there, this lesion or the mass which is there inside the breast, okay, this is actually a benign lesion. And in the second condition, can you see this mass inside the breast? Yes, this mass or this lesion inside the breast which is there, this is actually a malignant lesion that you have to be aware of. Now if I talk about the basic differences between both of them, this is actually a benign lesion. Just a minute. This is nothing but a benign lesion that you have to be aware of, and this is nothing but a malignant lesion. How are we going to differentiate? There are three important features that we have to look for. The first thing that you have to look for in a benign lesion, can you see definitely the margins of this benign lesion are well defined. Okay, उस margin के बाहर जा रहा है क्या mass? नहीं जा रहा. So there are well defined margins usually in a benign breast region. Okay, there are well defined margins usually. Okay, there are well defined margins in a benign breast region, that has to be remembered. Next important, if I talk about, okay, next important if I talk about is the malignant breast region. In a malignant breast region, please remember, here you have to remember that this lesion which is there, it is not having a well defined margin, rather there are irregular margin. कोई भी margin दिख रही है क्या? No, there are very irregular kind of margins in this. Okay, rather spike like margins are present, therefore these are the irregular spiculated margins. Okay, over here definitely we are going to have what? Okay, in this malignant lesion बच्चों, we are going to have actually irregular speculated margins. We are going to have irregular speculated margins. The margins will be different in both the conditions. You have to remember that. Please remember the margins which are present in a benign breast regions are well defined, but the margins which are present in a malignant breast region are irregular and speculated breast margins. Next important, you have to remember that in a case of benign breast region, there is actually a halo. Can you see a black area around the region? Yes. So around a benign breast region, there will be a halo around the region. Okay, that has to be understood. There will be a halo around the lesion. There will be halo around the lesion in a case of benign breast tumor. But if it is a malignant breast tumor, you have to remember malignancy. अगर cancer होगा, तो definitely तुम्हें जो लग रहा है, दिख रहा है, the structure of the breast, is it normal now? No. The architecture of the breast which is there, the texture of the breast, the structure of the breast has been damaged completely. That means there is an architectural distortion. जो architecture होता है definitely वो खराब हो चुका है. ठीक है, so definitely in a malignant breast region there is an architectural distortion. There is an architectural distortion बच्चे. ठीक है, there is an architectural distortion. And last important is calcification. We can see some calcium deposition inside the breast mass or this breast lump. Definitely you have to remember that the calcium deposition in a benign breast region which is there, it is very large in size. बड़ा सा calcium deposition दिखता है तुम्हें. That is what is called as a macro calcification. But in malignant one that you can see बच्चे, malignant one वो तुम्हें भले बड़ा लग रहा है size में malignant वाला, but actually these are very small calcifications which have combined together. ठीक है, ये बहुत छोटे calcifications है. These are known as micro calcifications. ठीक है, so please remember macro calcification which is there. Macro calcification which is there, it is a classical feature of a benign breast region. Macro calcification. I hope all of you might have heard about a popcorn calcification which is seen in fibroadenoma of breast. So fibroadenoma is the most common benign tumor of breast, and definitely the popcorn calcification which is seen, it is an example of macro calcification which is seen in the benign breast tumor. Okay? And whereas if I talk about a malignant breast tumor, here definitely you are going to have micro calcification. Here definitely you are going to have microcalcification. These are the basic differences. These are the basic differences between a benign and between a malignant breast region on mammography. Benign में well defined margins, malignant में irregular spike like margins. ठीक है, benign में there is a halo around the region, malignancy में there is a complete distortion, okay, of the architecture. In benign definitely there is a macro calcification like a popcorn calcification, but in malignant there is very small micro calcifications. ठीक है, that is important to be remembered. Now let's discuss further. We have discussed about the mammography. Now the other imaging techniques or other radiological investigations were ultrasound and MRI. So let's talk about them somewhat. If I talk about the ultrasound now, we have to remember that the ultrasound is the investigation or the imaging modality of choice. It is the investigation of choice or imaging modality of choice. In which conditions? First of all, to differentiate between a solid and a cystic mass. Yes. For example, okay, for example, a patient comes to you with a breast lump and you have to differentiate whether the patient is having a solid mass or a cystic mass. Okay, solid mass matlab which is completely made up of tissues itself, and cystic mass matlab which is actually a sac which contains some amount of fluid inside it. And हमें पता है जहां जहां fluid आएगा वहां वहां ultrasound use किया जाएगा. Wherever there will be fluid, we have to use a ultrasound over there. So you have to remember, when we have to differentiate a solid mass from a cystic mass, the investigation of choice or the best investigation radiologically, it is going to be the ultrasound itself. Okay? Next important, we have discussed already that ultrasound is also done in a young lady, okay, that is usually less than 40 years of age, and definitely in a pregnant lady for screening of a breast lump. For screening of a breast lump, definitely. Okay, so screening test for a breast cancer and investigation for a breast lump in a patient who is young, less than 40 years of age, or a patient who is pregnant. In both the conditions, the imaging modality of choice will be a ultrasound itself. Okay? No issues with this, anybody? That has to be remembered. Next important is if I talk about MRI now. MRI की अगर मैं बात करूँ, please remember, MRI is the investigation of choice. MRI is the investigation of choice in the sense radiological investigation of choice, rather I'll mention it. Okay, so MRI is actually the radiological investigation of choice in a case of high risk female. For example, there is a high risk female who is coming to you with a breast lump. Okay, what is a high risk female? The female who is having either a family history of breast cancer or the female who is having BRCA gene mutation. Okay, these are considered as high risk females. In these females, definitely the radiological investigation of choice for examination of a breast lump is to be a MRI. It has to be a MRI. Please remember this. Okay? So if I talk about this radiological investigation of choice in a high risk female, it has to be MRI. In a high risk female with breast lump, rather I would say. In a high risk female with breast lump. No issues with this, anybody? That has to be remembered. Next important is definitely it is also the radiological investigation of choice for a patient who is coming to you with a breast lump, but she is also having a breast implant. So any patient who is having breast implant, definitely for that patient also the radiological investigation which will be preferred. It cannot be ultrasound, it cannot be a mammography, because on ultrasound and mammography, due to the presence of breast implant, you will not be able to properly identify the breast region. That is the reason you have to use a better one, that is MRI. And MRI is also used to identify local recurrence and scar recurrence. What do I mean by this? Definitely, for example, please remember, the patient had a breast cancer earlier. Okay, and now again the patient is having recurrence of breast cancer. Again the breast cancer has reappeared. So in this patient also the investigation of choice radiologically has to be a MRI itself. ठीक है, वापस से अगर कैंसर हो जाता है तो, या फिर if the patient is having a scar on the breast tissue, for example, the patient had a previous surgery for breast, and due to that there is a lot of big scar on the breast tissue. So if there is a lot of scar on the breast tissue, ultrasound and mammography, okay, can give mistaken findings. Yes, ultrasound या mammography पे कुछ गलत दिख सकता है हमें, definitely if there is a lot of scar, because the penetration will not be better. That is the reason if the patient is having a lot of scar on the breast, then better investigation has to be a MRI. No issues with this, anybody? High risk का मतलब बच्चों family history of breast cancer or a female with BRCA gene mutation. ठीक है, that is what is a high risk. Next important, if I talk about breast implant rupture, जब breast implant rupture हो जाता है, you just have to remember the name of the sign Okay, breast implant rupture में the name of the sign which is there. See, this is the case of a breast implant rupture. Okay, can you see this is the breast implant? It is a silicone gel implant, and definitely what has happened? There is an intracapsular rupture in the patient. There is an intracapsular rupture in the patient. This sign which is there, where the capsule is actually, this is the capsule, right? Can you see the capsule which is there? It is floating inside the breast implant. This capsule floating inside the breast implant, bachcho, is what is classically called as the Linguini sign on the MRI. Okay, if we do a MRI for a patient of breast implant rupture, we are actually going to see this classical sign where the capsule is actually floating inside the implant, and this is what is called as a Linguini sign. Okay, so please remember MRI pe you have to remember this is a previous year question, not image based, direct question. So it is Linguini sign which is seen on a MRI in a intracapsular breast implant rupture. In an intracapsular breast implant rupture on a MRI we are going to see the classical Linguini sign. Okay, next important you have to remember is on ultrasound what will be seen. On ultrasound, in a case of intracapsular breast implant rupture, we are going to see a step ladder sign. Very good. So please remember, in a case of intracapsular breast implant rupture, मतलब capsule अभी भी intact है, but there is an intracapsular rupture definitely. So please remember, in this condition, intracapsular breast implant rupture on an ultrasound, it is going to show us the step ladder sign or the step ladder pattern. Whereas in the extracapsular rupture, it is going to show us the snowstorm pattern or the snowstorm sign. It is going to show a snowstorm appearance on the extracapsular breast implant rupture. In extracapsular breast implant rupture, we are going to see the classical snowstorm appearance. We are going to see the classical snowstorm appearance. Got it? So that has to be remembered, bache. That has to be remembered. And the last thing that we saw in triple assessment was nothing else but histopathological examination. Okay, histopathological examination. If I talk about HPE, I told you histopathological examination can be done by two methods. First is definitely your FNSE. What is FNSE? FNSE is nothing but fine needle aspiration cytology, and second is nothing but a true cut biopsy. Important is FNSE or your fine needle aspiration cytology. FNSE or your fine needle aspiration cytology जो होता है बच्चे. Okay, here we are going to use a very small needle because here we just have to take out the cells itself. हमें tissue नहीं निकालना, we just have to take out cells. So definitely with the help of a very fine needle we are going to take out these cells, and then definitely we are going to send it to the pathology lab where the pathologist is actually going to see these cells under the microscope, and then he is going to tell us whether the patient is suffering from a benign lesion or from a malignant lesion. Okay, so that is the important thing you have to be aware of. Okay, so fine needle aspiration cytology mein the size of the needle which is used, that is important to be remembered. The size of the needle which is used, it is 22 to 30 gauge. Yes, please remember, as I've already discussed, as the size of the needle sorry, as the gauge of the needle increases, you have to remember the size of the needle is going to decrease. So 22 to 30 gauge needle is a very fine needle which will be there. 22 to 30 gauge needle is commonly used for fine needle aspiration cytology, and these are the common questions which will be asked. Okay, so please remember that. Next important is definitely if I talk about a true cut biopsy. If I talk about a true cut biopsy, definitely true cut biopsy, as I've told you, it is the single best investigation for diagnosis or for investigation of a breast cancer. It is the single best investigation. It is the investigation of choice. That has to be remembered. Investigation of choice for breast cancer. Single best answer mark karna hai. Answer has to be a true cut biopsy usually. Next important is, please remember, true cut biopsy की अगर मैं बात करूं, please remember needles will have different color codings. Okay, needle will not have the same color codings as cannula. Needle के भी अलग होते हैं अपने, ठीक है. True cut biopsy is the investigation of choice, and this true cut biopsy which is there बच्चों, it can be ultrasound guided as well. You can do ultrasound, and then with the help of the ultrasound you are going to perform a true cut biopsy. True cut biopsy is actually done with the help of a biopsy gun. Okay, and the size of the needle which is used in the true cut biopsy, you have to remember, यहाँ थोड़ी बड़ी size लगेगी because in the biopsy we are going to take tissue, and अगर tissue निकालना है तो definitely बड़ी size की needle लगेगी, and that is usually the size of the needle that we use. It is actually a 8 to 18 gauge needle, and the previous year question which was asked, in that the option was 16 gauge needle. So you have to remember the best one to be used is the 16 gauge needle. 8 to 18 gauge needles can be used, but the best one which is used is actually the 16 gauge needle which is commonly used. Okay? Now when we are actually performing the biopsy, Can you see? Definitely this is the ultrasound probe which we are keeping over the mass, and with the help of that, definitely with the help of this biopsy gun, we are going to perform the biopsy. Okay, so please remember, usually true cut biopsy and core cut biopsy are almost similar. Okay, they are almost similar. There's not such a major difference between them. Important is definitely what are we going to do over here. See, over here we are going to take this biopsy gun. Okay, we are going to insert it in the skin of the patient. For example, consider this as the skin of the patient. We are going to insert it at the level of the mass. Once we have inserted it in the skin, then definitely we are going to press this button. As we are going to press this button, definitely, okay, what is going to happen? The needle is going to go in front. The needle is going to go in front, and this needle is going to go inside the mass. ये needle कहाँ घुसेगी? Mass में जाएगी. This needle will go inside the mass, बच्चे, definitely. Okay, once it goes inside the mass, definitely we are going to actually try to take some amount of tissue from there, from the mass. By manipulation we are trying to take some mass from there, and once we have taken the mass, then definitely we will pull back the needle. Yes, ये covering बाहर ही रहती है, यहाँ थोड़ा सा गलत interpretation है. This covering is left outside, only the needle goes inside. ठीक है? And then definitely we pull back the needle, and then we slowly remove it out. Then we slowly remove it out from the skin. Important is, as I've told you, usually, okay, for tumors, generally the investigation of choice has to be a biopsy, which is the best one, whether it is a benign tumor or a malignant tumor. Okay? It is always a biopsy most of the times. Important is, please remember, I've told you only two tumors where definitely biopsy will not be preferred. Please remember, first is definitely highly vascular tumor. Because if in a highly vascular tumor, you go for a biopsy, the patient will bleed to death itself. The patient is going to bleed to death itself. That should be taken care of. First thing. Second important thing that you have to be aware of, in any cancer where there is a risk of spread. Okay, in any cancer where there is a risk of spread. For example, the liver cancer or the kidney cancer. In liver or kidney cancers, you have to be aware that the patient will have a risk of spread of the cancer. ठीक है? क्यों? When you take a biopsy from these cancer, for example, liver cancer से जब तुम biopsy दे रहे हो, definitely you are going to spread this cancer into the peritoneum. You are going to spread this cancer actually into the peritoneum or into the abdominal wall. So if there is a risk of spread of the cancer while taking a biopsy, again in that condition you do not have to do a biopsy. Therefore, in liver and kidney cancer or even in a gallbladder cancer, the investigation of choice will be a CECT abdomen, that is a contrast enhanced CT scan of abdomen that will study in GIT and hepatobiliary. ठीक है? तो that's the important thing. Biopsy is done in anesthesia? No. यहाँ पे ये local biopsy होती है बच्चे. Definitely we will just infiltrate local anesthesia over here. ठीक है? Just before doing the biopsy, we are going to infiltrate local anesthesia around the mass. ठीक है? Lignocaine या xylocaine use कर सकते हो तुम. ठीक है? No issues with this. यहाँ पे क्यों नहीं? यहाँ पे why there is not risk of spread? Because here actually we are pulling back the needle into the covering. Okay, and therefore we are removing the covering itself. Therefore, there is a less risk of spread in a case of biopsy of a breast cancer. And important is now, what is the investigation of choice for staging? So if you want to do a breast cancer staging, please remember the investigation of choice for overall staging of breast cancer. Staging is done by TNM staging, right? I'll talk about that. T for tumor size, N for the nodal metastasis, that means how many lymph nodes are involved, and M for distant metastasis, that means how many organs are involved. So for staging, definitely the investigation of choice you have to remember, it is the PET-CT. For staging, the investigation of choice you have to remember, it is the PET-CT itself. Okay? For distant metastasis, if I talk about, for distant metastasis, please remember the investigation of choice is what? It is the PET scan. Okay, what is PET? Definitely positron emission tomography. Positron emission tomography or a PET scan is the investigation of choice for distant metastasis. For example, if the cancer spreads to any other organ, okay, in that condition, PET scan will be the investigation of choice. याद रखना, PET scan is actually a whole body scan. Yes, it is a whole body scan. Important, what is the dye used over here? What is the contrast used over here? So please remember, जो PET scan होता है, इसमें the contrast which is used, बच्चे, it is known as 18 FDG. It is known as 18 FDG. This has been a previous year question. 18 fluorodeoxyglucose. Okay, so 18 fluorodeoxyglucose is the dye or the contrast which is used in a case of PET scan. Why glucose we are going to use over here? Because I hope all of you are quite aware. Yeah, TNM classification of staging, I'll be talking about it. I'm starting with breast cancer. Abhi breast cancer start नहीं हुआ है. We are just talking about the basics. 18 FDG, if I talk about बच्चे, definitely 18 fluorodeoxyglucose. Why glucose we are using over here? Because we know that the cancerous cells which are there, They are having rapid division, and due to that rapid division, they need a lot of energy, right? We have studied Warburg's effect as well in biochemistry, right? So definitely cancerous cells or malignant cells need a lot of glucose. Therefore, wherever there will be malignant cells in the body, they are going to take up a lot of glucose, and that will be seen on a PET scan. So apart from, for example, the breast, wherever there will be increased uptake of the glucose, apart from brain also, brain में तो normally होता है ज़्यादा glucose. So apart from the breast, definitely wherever there will be increased glucose uptake, you will be able to see, okay, the cancer has metastasized to this particular area. Okay, so that is what that is the reason why we use 18-fluorodeoxyglucose as the dye or the contrast for a PET scan. Important is the half-life of this has also been asked. कितनी होती है half-life? So please remember the half-life of 18 FDG is 110 minutes. The half-life of 18 FDG is 110 minutes. That means it remains for 110 minutes in our body and then it is washed off. Okay, because after PET scan we don't want it in our body. Therefore, the half-life for this is around 110 minutes. No issues with this, bache. That has to be remembered. Okay. Now let's talk about the reporting system. What is the reporting system? For example, a radiologist has done ultrasound or a MRI or even a mammography in a patient of breast lump. Now, definitely we want the result. Okay. Now, problem is definitely what was to happen कि ये radiologist अलग तरीके से report बनाता था, वो radiologist अलग तरीके से report बनाता था. Every radiologist has their own way of reporting. So that was creating a lot of problems. We were not able to get a clear idea that which stage of breast cancer it is and how we want to approach the breast cancer. For that, actually we thought it's better to come to a conclusion and we have a standardized way of reporting. Every radiologist worldwide will report the breast lump in the same manner. If they are investigating a breast lump with the help of an ultrasound, mammo or a MRI, they have to report it in the same manner. Okay? And that standardized way of reporting, that system is known as BIRADS. What is BIRADS? Breast Imaging Reporting and Data System. Okay? Why data system? Because once the radiologist has reported it, he has to keep this format saved with him for further use as well. Okay? So that's the important thing. On the computer, it has to be stored as well. So important, and it will be shared with the clinician who is responsible. So if I talk about the BIRAD scoring system, BIRAD's ka full form you have to remember, it is the Breast Imaging Reporting and Data System. It is the Breast Imaging Reporting. It is the Breast Imaging Reporting and Data System. Important is the same systems are also available for liver cancer. The same systems are also available for your prostate cancer, even for thyroid cancer. Okay, and therefore those will be called as, for thyroid it will be called as TIRADS, for liver it will be called as LIRADS, for prostate it will be called as PIRADS. Okay, so it is the same. Imaging, reporting and data system remains same, only the name of the organ differs. Okay, so BIRADS is the most common one that we use, that is Breast Imaging Reporting and Data System. Okay, depending on this, definitely we are going to decide the further management in a patient of breast lump. Okay, now what is BIRADS? As I've told you, it is a standardized way of reporting a mammogram or ultrasound or a MRI in a patient of breast lump usually. ठीक है, एक standardized तरीका होता है इन तीनों investigations को report करने का. हर radiologist को पूरी दुनिया में इसी तरीके से report करना होता है. ठीक है. So now, if the radiologist says the BIRAD score is 0, okay, that means he is saying we need additional imaging. For example, you send the patient for a mammography and on that report it says the BIRAD score is 0. So it's better in this patient now you have to go for an ultrasound or an MRI further. Okay? If he says it is BIRADS 1, BIRADS 1, that means there is negative report. That means there is no breast lump as such. Okay? There is no breast lump as such. It might be a fat tissue which might be felt. But on the investigation, you are not able to get anything. Okay? So BIRADS 1 का मतलब होता है negative. And what should be done in a negative report? Definitely routine screening. Routine screening, I have already told you, it is done with the help of a mammography. Okay. Usually when the patient is more than 40 years of age and it is done annually. That means every 1 year you have to undergo a mammography. Okay? So that is what is continued in the patient. If it is a score of BIRADS 2, BIRADS 2 matlab he says it is 100% benign tumor. Okay, BIRADS 2 matlab with the help of this he always says it is a 100% benign tumor. And if it is a 100% benign, do we do anything for it? No. Again, routine screening will be continued. Yes, every 1 year we have to call the patient for a follow-up. Okay, or a routine screening has to be continued. But if it is a BIRADS 3, this is a matter of concern now. If it is a score of Byrat's 3, so you have to remember he is saying it is probably benign. What do I mean by probably benign? That there are chances that this tumor or this lesion can be malignant. Okay, वो बोल रहा है probably benign. Majority of the times it is benign only, but there are few chances that it can be malignant also. Okay, less than 2% chances he says usually. He says less than 2% chances that this cancer can be malignant. Okay, less than 2% chances that it can be malignant, but he is saying na ki there are chances it can be malignant. Okay, so in this condition he is not sure, so in that condition it's better that we don't go for a routine screening, rather we ask the patient to come for a short interval follow-up. We ask the patient to come for a short interval follow-up definitely, and short interval follow-up is done every 6 monthly. ठीक है, हर 6 महीने में बुलाओगे, rather than 1 year you will call the patient every 6 months, every 6 monthly, and you are going to do a triple assessment in this patient. ठीक है, or at least you are going to follow up this patient after every 6 months with the help of some ultrasound or a mammography. ठीक है, depending on the age group, हर 6 महीने में तुम्हें अल्ट्रासाउंड या मैमोग्राफी रिपीट करनी होगी पेशेंट में. ठीक है, तो दैट हैज टू बी डन. नेक्स्ट इंपॉर्टेंट इज Byrat's 4 now. Byrat's 4 says it is suspicious. That means the radiologist is not sure whether it is benign or malignant. Byrat's 3 में क्या था? He was saying there are more than 70% chance, or rather more than 90% chance it is benign in nature, but very few chances, less than 2% chances that it can be malignant. But in a case Byrat's 4, definitely he is saying it is suspicious. 50-50% chances दोनों हो सकता है definitely. ठीक है, so in Byrat's 4 the radiologist is suspicious. He says there is 2 to 95% risk. Yes, there is 2 to 95% risk of a malignancy. याद रख लो, there is 4A, 4B, 4C also, but you just have to remember 2 to 95% risk if it is there for a malignancy. It is Byrat's 4, and if there is so much of risk, better is to go for a biopsy only now. Better is to go for a tissue diagnosis that is done by biopsy itself. Then if there is Byrat's 5, Byrat's 5 is highly suggestive of a malignancy. Byrat's 5, he is saying more than 98% chance. Okay, there is more than 95 or more than 98% chance that it can be a case of malignancy. More than 95 or 98% chance then it can be a case of malignancy. So in that condition, obviously if he is saying there is very high chance of malignancy, we have to confirm it further with the help of tissue diagnosis done by a biopsy. And lastly, if it is Byrat's 6, Byrat's 6 is what? It is a biopsy proven malignancy. तुम बोलोगे sir, if it is proven by the biopsy already, why are we sending the patient to a radiologist then? बच्चे, we have to go for a surgery in this patient, and for that, after the biopsy is confirmed that it is a malignancy, we also have to check how many structures have been involved. Okay, what is the extent of this breast cancer? Okay, so for all of that purpose, we have to do a radiological investigation, and for that purpose, we are actually sending the patient again back to the radiologist. So if it is already a confirmed malignancy, he just has to comment on the other things, the size, the extent of the breast cancer, then it will be written as Byrat's 6 because it is already confirmed on a biopsy. And here definitely the next step is always surgical excision. ठीक है? So these are the various types of Byrat's. बच्चों, you have to remember, याद रख लो कौन से याद रखने लायक है. They are definitely Byrat's 3 because it is probably benign. What should be done over here? Short interval follow-up every 6 months we have to do. Next important, it is Byrat's 4 because it is suspicious case. In that condition, definitely you have to do a further step as biopsy in the patient. Byrat's 5 तो always a biopsy definitely. ठीक है, so these are the important. 3 and 4 are the most important to be remembered. ठीक है, याद रखना, इसी पे क्वेश्चन आता है बहुत बार. Now let's talk about the next one. Now if I talk about breast cancer, we know बच्चे there are few cancers in the body which are hormone dependent or which are hormone driven. That means the size of these cancers usually they increase with increased levels of hormones. For example, तुम्हारा endometrial cancer. Okay, second is your breast cancer. Third can be your ovarian cancer. Fourth important can definitely be your prostate cancer in males. ठीक है? So these are few cancers of your body that you have to remember which are hormone dependent cancer. That means as the level of the hormone will increase, there will be more stimulation of these organs and therefore there will be more proliferation or more cell division, causing increase in the size of the cancer as well. ठीक है? So why it is important to know these cancers? Because the cancers which are hormone dependent, okay, the cancers which are hormone dependent, क्या होता है? See, for example, this is the breast cancer tissue, okay, and it is actually having receptors for your estrogen. Okay, it is actually having receptors for your estrogen definitely. So this estrogen will come and bind to it and it is going to stimulate it. When it stimulates it, definitely there will be more cell division. There will be more cell division and there will be increase in the size of the cancer. The size of the cancer is what? It is going to increase. But can we do like this? For this particular cancer, can we block these receptors itself? Yes, we can block the receptors, so that if we block the receptors on the malignant cell surface, definitely can your estrogen bind to it? No. Definitely if the estrogen cannot bind to it, okay, will there be increase in the size of the cancer? No. Therefore, the cancer will start shrinking inside. The cancer will start reducing in size, that you have to remember, bache. And most of the times the cancer will even go away. Yes, most of the times the cancer will even go away. Almost इतना छोटा हो जाता है कि उसके बाद वो डेवलप ही नहीं होता आगे. ठीक है? So that's the important thing you have to remember, that cancers which are hormonal dependent, they can be treated by hormonal therapy also. Yes, cancers which are hormonal dependent, they can be treated by hormonal therapy as well. Okay, इसीलिए याद रखना है, because there was a previous year August FMG 2020 question, which among the following cancer is treated by hormonal therapy, and in that option was not breast cancer. The other option which was given was prostate cancer, because prostate cancer is dependent on testosterone, just like endometrial and breast cancer are dependent on estrogen. ठीक है, तो याद रखना है बात. Because we know there are two hormones which will act on the breast mainly. One is the estrogen, second is the progesterone in the reproductive age group. Definitely estrogen causes what? Estrogen causes proliferation of the glandular epithelium. जो ग्लैंड्स में तुम्हारा एपिथेलियम होता है ना, उसका सेल डिवीजन या उसका प्रोलिफरेशन करवाने का काम कौन करता है? ईस्ट्रोजन करवाता है बच्चे. एंड देन डेफिनेटली स्टेबलाइजेशन इज कॉज्ड बाय प्रोजेस्टेरोन. And next, milk synthesis, we know definitely it is caused by prolactin, and milk ejection which is there, it is caused by oxytocin. Okay? That is important. But here we have to remember the more important hormone which causes cell division or proliferation inside the breast, okay, which will be responsible for increase in the size of the breast, is your estrogen mainly. Okay, that is the reason why estrogen is mainly responsible for breast cancer. Sorry. So we know that breast cancer is a hormone driven cancer. Risk factors, if I talk about, definitely any condition which is going to increase estrogen levels in the body. Okay, anemia is what? Anemia means blood, definitely. Sorry, anemia is what? Anemia is nothing else but blood. In blood there is increased levels of estrogen, that is hyperestrogenemia. Now important is, if I talk about hyperestrogenemia, you have to remember what are the conditions where there will be excess of estrogen in the patient's body. First is early menarche. What is menarche? Start of menses. Menses जब start होते, that time is what is called as menarche. Okay, so please remember, if a patient is having early menarche, normally usually menses start around 13 years of age, but in some patients definitely the menarche the menses started at around 8 years of age. If the menses started around 8 years of age in this patient, definitely she had more number of menstrual cycles or less number of menstrual cycles. As the menses started earlier, her reproductive age group was longer, and therefore she had more number of menstrual cycles. As she had more number of menstrual cycles, she had more exposure to estrogen or less exposure to estrogen? Definitely she had more exposure to estrogen. हर महीने वो estrogen को expose होती है, definitely, right? She has more exposure to estrogen, and if she is having more exposure to estrogen, definitely the risk of breast cancer is going to increase. Okay, so that's the important thing. Second important is late menopause. What is menopause? When the menses are going to stop. Menses जब रुक जाएगी उसको बोला जाता है menopause. Okay, usually around 47 to 51 years of age they usually stop. But if a patient had menopause at around 57 years of age, now she had a very late menopause at 57 years, definitely she had a more longer reproductive lifespan. As she had more longer reproductive age group, therefore definitely she had more number of menstrual cycles. Again the same logic applies. More number of menstrual cycles, more exposure to estrogen, high risk of breast cancer. So early menarche and late menopause, these are important keywords, bache, and on these questions have been asked in your previous year examination. People get confused. Okay, so that should not happen now. Okay, just apply the logic. Number of menstrual cycles will be more in which condition. Okay. Next is obesity. Now why obesity is a risk factor and why it is causing hyperestrogenemia? I hope if a patient is obese, all of you are quite aware that the patient will have more amount of which tissue in the body? The patient will have a lot of adipose tissue in the body. Okay, the patient will have a lot of adipose tissue in the body, and this adipose tissue, bache, contains an enzyme known as aromatase. This adipose tissue contains an enzyme known as aromatase. What the aromatase is going to do? This aromatase is going to convert your androgens into estrogen. Yes, this aromatase is going to convert your androgens like testosterone into your estrogen. Important is, if a patient is having obesity, there is more amount of adipose tissue. That means there is more amount of aromatase in the body. If there is more amount of aromatics in the body, more conversion of androgens into estrogens, therefore there will be more amount of estrogens in the patient's body as well. That is hyperestrogenemia. That is the reason why obese patients are at a higher risk of developing breast cancer. No issues with this, anybody? Next is HRT. What is HRT? Hormone replacement therapy. Usually the menopausal females which are there, in these patients we can give a hormone replacement therapy. Okay, in hormone replacement therapy we give estrogen as well as progesterone. But high doses or low doses, bachche? Definitely, please remember, we give high doses of estrogen and progesterone. Okay, so that is important to be remembered. You have to remember that this high doses of estrogen and progesterone which are there, याद रखना, फैट इंटू एस्ट्रोजन, फैट का डायरेक्टली एस्ट्रोजन में कन्वर्ट नहीं हो सकता, फैट को पहले एंड्रोजन्स में कन्वर्ट करना होता है, एंड देन दिस एंड्रोजन्स आर कन्वर्टेड फर्दर इनटू एस्ट्रोजन. यू माइट हैव स्टडीड इन ऑब्स्टेट्रिक्स द साइकिल ऑफ योर इन गायनेकोलॉजी, जो तुम्हें ये फैट ब्रेकडाउन बताया होगा. डेफिनेटली इन दैट यू माइट हैव स्टडीड अबाउट योर 17-dehydroxyprogesterone एंड ऑल ऑफ दैट. ओवर देयर यू विल कम अक्रॉस दिस. ठीक है. सो नेक्स्ट इंपॉर्टेंट इज हाई डोसेस ऑफ एस्ट्रोजन एंड प्रोजेस्टेरोन. प्लीज रिमेंबर, हाई डोज में अगर तुम एस्ट्रोजन या प्रोजेस्टेरोन देते हो बच्चे, देन डेफिनेटली द रिस्क ऑफ ब्रेस्ट कैंसर विल बी हायर इन द पेशेंट. बट इफ दे आस्क यू लो डोज COCP, कैन लो डोज COCP बी अ रिस्क फैक्टर फॉर ब्रेस्ट कैंसर? कैन लो डोज combined contraceptive, oral contraceptive pills be a risk factor for breast cancer? No. You have to remember, low dose COCPs are not a risk factor for breast cancer. They are not a risk factor for breast cancer. Okay, so that's the important thing. Next important is nulliparity. What is nulliparity? A patient who has never delivered. A patient, nulli gravida bolo, nulliparity bolo. Definitely a patient who has never been pregnant or who has never delivered a child. In this patient, were there any pause for the menstrual cycles? No. Reason is क्यों? ये देखो, जब भी पेशेंट प्रेग्नेंट होती है, उस टाइम के लिए मेंसेस रुक जाते हैं. देयर इज अमेनोरिया. Second, even in the lactation period or in the breastfeeding period, at least she is having amenorrhea, right? So she gets a break. She gets actually a pause from the menstrual cycles for a very long duration of time. So therefore, a patient who is pregnant, she is going to get a lot of breaks from the menstrual cycle, and therefore the level of estrogen in this patient or the exposure of estrogen in this patient will be low. But if a patient who has never been pregnant, वो कभी pregnant ही नहीं हुई, or the patient who has never delivered a child, okay, for example, one and the same thing. So in this patient, definitely, was there any pregnancy? No. If there was no pregnancy, was there any lactation? No. If there was no pregnancy and no lactation, did she get any breaks from the menstrual cycle? No. So the number of menstrual cycles in the females was more, definitely. As the number of menstrual cycles in the females was more, definitely the exposure for estrogen was more, definitely, and as the exposure for estrogen was more, definitely the risk of breast cancer is also very, very high in the patient. ठीक है. Okay, so never pregnant अगर कोई patient है, okay, nulli gravida या nulliparous woman, in that patient you have to remember बच्चे that the patient will have a very high risk of breast cancer. But okay, what are the protective factors? If I say protective factors, usually will be pregnancy and lactation, right? Pregnancy and lactation, because they are going to give what? Pregnancy and lactation are definitely going to give break from the menstrual cycle, and that is the reason why we can say a patient who is having pregnancy, who is having lactation, or who is a multigravida, for example, who has been pregnant for a very number of times now, definitely that patient will have less risk of breast cancer. ठीक है. No issues with this, anybody? Next important risk factors that you have to be aware of is increasing age. Yes, increasing age usually is an important risk factor for breast cancer. That is the reason why we start usually breast cancer screening at around 40 years of age. Reason is the incidence of breast cancer is more common in the perimenopausal females. That is usually after 40 years of age. ठीक है, perimenopausal I am saying 40 years of age. ठीक है. Important is another risk factor can be alcohol. Alcohol can also be one of the important risk factors for the patient, and smoking. Smoking is controversial. That means smoking is definitely an important risk factor for elderly females, but smoking is actually considered protective for younger females. ठीक है. Yeah, smoking is considered protective for the younger females for breast cancer. ठीक है. So that is a risk that you have to be aware of. वो प्लस माइनस वाला है, वो controversial है थोड़ा सा, बाकी definitely they are the risk factors for sure. Next important, if I talk about genetics now, okay, which gene mutations are known to cause breast cancer, that you have to be aware of. The gene mutations which are known to cause breast cancer, first of all बच्चे, breast cancers are of two types, ठीक है. One is familial breast cancer. Familial breast cancer का मतलब the breast cancer definitely which will run in the families. As the breast cancer is running in the family, that means the patient is having definitely some gene mutation. Okay, as the patient is having some gene mutation, you have to remember उस जीन म्यूटेशन की वजह से क्या होता है, द पेशेंट इज हैविंग अ कांस्टेंट स्टिमुलस और कांस्टेंट ग्रोथ ऑफ द breast cells or the breast tissue usually, and therefore there is development of a breast cancer in this patient. ठीक है, so usually familial जो होता है, it is only 10% cases, yes, which runs in the family. मतलब माँ में था, बेटी में आया, and there is, it is also seen in the granddaughter. मतलब if there was breast cancer in the grandmother, it came into the mother, it went into the granddaughter as well. This type of breast cancer is what is a familial or a hereditary breast cancer. Whereas most of the cases or majority of the cases of breast cancer are not familial, sporadic in nature. They are sporadic in nature. That you have to be aware of. Now, please tell me what is the most common gene mutation responsible? The most common gene mutation which is responsible for the familial breast cancer, bache, it is definitely the BRCA1 or the BRCA2 gene mutation. It is definitely the BRCA1 and the BRCA2 gene mutation. Okay, the most common one in the familial breast cancer is BRCA1 and BRCA2. But if they ask you which is the most common gene mutation in sporadic breast cancer, okay, which is the most common gene mutation in a sporadic breast cancer, then you have to be aware of it. It is P53 gene mutation. Rather, I hope all of you are quite aware that P53 is the most common gene mutation implicated in all malignancies of the body. Body में कोई भी malignancy हो, जो सबसे common gene mutation होता है, that is P53, because P53 gene is considered as the policeman of the human genome. Yes, it protects our genes, it protects our genome. But अगर P53 खुद ही खराब होगा, the patient can develop multiple cancers. Okay, P53 gene mutation can lead to multiple cancers in the body, and that syndrome is known as Lee-Fraumeni syndrome. That you might have heard about it. Okay, Lee-Fraumeni syndrome. That has to be remembered. ठीक है? So याद रख लो, in a sporadic breast cancer, the most common gene mutation which will be seen is a P53 gene mutation that you have to be aware of. तो अब अगर question पूछा जाता है, which is the most common gene mutation in breast cancer? Answer is not BRCA1 or BRCA2. Answer is P53, because the basic logic says that majority 90% of the cases of breast cancer are sporadic, and the most common gene mutation in sporadic is P53. That is the reason most common gene mutation in sporadic is always P53. Overall also is P53. Only 10% cases of breast cancer are familial in nature, and therefore familial के लिए the most common gene mutation is BRCA1 or BRCA2. कोई दिक्कत नहीं है बच्चे, that has to be remembered. Next important is, if I talk about the BRCA1 or BRCA2 gene mutation, you have to remember the BRCA1 gene is located on chromosome number 17, whereas BRCA2 is located on chromosome number 13. ठीक है, BRCA1 on chromosome number 17, the long arm, and BRCA2 on the chromosome number 13, the long arm. ठीक है, क्यों बोलते हैं उसको? If there is BRCA1 gene mutation which is more common, बच्चे, the BRCA1 gene mutation which is more common actually, in this you have to remember there is more aggressive kind of a breast cancer which will develop. Okay, यहाँ पे the breast cancer which is going to develop will be a more aggressive. What do I mean by aggressive? The cancer which is rapidly growing in size, or the cancer which is actually involving a lot of structures in the surrounding. ठीक है, so rapidly growing cancer and invading cancer is what is an aggressive cancer. So BRCA1 gene mutation की वजह से जो cancer होता है, that is more aggressive in nature. It is a basal type of breast cancer. I'll talk about the molecular classification over where I'll tell you what is the basal type of breast cancer. And third, the patient will have a poor prognosis. Definitely, if it is a more aggressive kind of a breast cancer, patient is going to have a poor outcome or a poor prognosis. If I talk about the BRCA2 gene mutation, the breast cancer due to BRCA2 gene mutation, bache, it is less aggressive in nature. It does not rapidly grow. Second, it is the luminal type. As I've talked about molecular classification, I'll talk about what is the luminal type of breast cancer. So BRCA2 gene mutation mainly causes a luminal type of breast cancer that you have to be aware of. And next, it will have a better prognosis. Okay? If it is less aggressive in nature, definitely if it is less rapidly growing, it will be having a better or a good prognosis as well. Important is if I talk about the BRCA gene mutation is associated with high risk of what? BRCA gene mutation is associated with high risk of OCP cancer. हाँ, ऐसे याद रखो, it will be easier. This is a mnemonic to remember. BRCA gene mutations are associated with high risk of OCP cancer. What is this OCP cancer? O goes for ovarian cancer, O goes for the ovarian cancer. C goes for the colorectal cancer. C for the colorectal cancer. And the P, there are two P's which you have to remember. One is the pancreatic cancer and second is the prostate cancer. Okay? So you have to remember BRCA gene mutations are going to increase the risk of which cancer? OCP cancers. O for ovarian, C for colorectal, P for pancreatic and prostate cancer. You have to remember the P which is there, bache. This P cancers which are there, that is whether it is your prostate or your pancreatic cancer. These P cancers are commonly associated with BRCA2 gene mutation. Yeah, they are associated commonly with BRCA2. Okay, ovarian and colorectal are associated with BRCA1, but please remember the P cancers, that is your pancreatic cancer and the prostate cancer, they are mainly associated with BRCA2 gene mutation more commonly. ठीक है, याद रखना ये बात. Okay, important is BRCA2 gene mutation which is there, it is also a more common cause of male breast cancer. याद रखना, if I talk about the incidence of breast cancer, 99% cases of breast cancer will occur in females. Yes, 99% breast cancer cases occur in female. Only 1% cases of breast cancer can occur in males, and that too in those males who are having gynecomastia, for example. Okay, enlargement of the breast, or the patients of Klinefelter syndrome. Okay, so definitely these patients who are having high risk of breast cancer usually, okay, they are the ones which have more amount of estrogen in their body. Okay, these male patients have high risk of breast cancer, or the male patients with the BRCA2 gene mutation. Yeah, look now. Overall, which BRCA gene mutation is a more common cause of breast cancer? It is BRCA1. In females, which BRCA gene mutation is a more common cause of breast cancer? Again, BRCA1. But in male breast cancer, which is a more common cause of breast cancer? It is BRCA2 gene mutation. Got it? So that has to be remembered. BRCA2 gene mutation is also responsible for male breast cancer. It is also responsible for a male breast cancer. Now, important is, bache, what is the most common site for a breast cancer? For example, if I talk about this, if this is my breast tissue, and if I divide my breast tissue into 4 quadrants, then you have to remember, bache, definitely this will be called as my upper outer quadrant, right? This will be called as my lower outer quadrant. This will be called as my lower inner quadrant, and this will be called as my upper inner quadrant, right? The most common site for your breast cancer, this is a previous year question twice in your exam. The most common site of your breast cancer has to be which one? It has to be this site over here. What is this? This is the upper outer quadrant. Okay, so please remember the most common site for a breast cancer, bache, you have to remember it is nothing but the upper outer quadrant. It is nothing but the upper outer quadrant. Okay, the most common site for a breast cancer is going to be the upper outer quadrant. कोई दिक्कत नहीं है यहाँ तक. That has to be remembered. ठीक है? This is a very common question. And if they ask you the least common site, yeah, be prepared for that as well. इसके completely opposite will be your least common site. इसके completely opposite कौन आता है? The lower inner quadrant. So please remember the lower inner quadrant will be the least common site. Okay? So the least common site of a breast cancer is going to be the lower inner quadrant. It is going to be the lower inner quadrant as well. Okay? So that is important. That will be the least common site for breast cancer. Now next, if I talk about is the most common type of breast cancer. Okay. Now first we will try to understand which are the main 2 categories of breast cancer. Okay, which are the main 2 categories of breast cancer. So you have to remember. See, I've told you there are 2 types of tissue in the breast, glandular and fat. Mainly the breast cancer will arise from the glandular tissue. Why? Because estrogen mainly acts on the glandular tissue. It causes proliferation of the glandular tissue, and definitely due to that the breast cancer mainly arises from the glandular tissue itself. ठीक है? अगर वो fat से arise होता, it will be not called as carcinoma, then it will not be a breast carcinoma, it will be called as a sarcoma, liposarcoma. That is a different thing altogether. Here we are talking about a breast carcinoma or a breast cancer. So in this, definitely you have to remember that this breast cancer can be there. It can arise from 2 things. There are glandular tissue which is there, bache. Glandular tissue is present. Okay, glandular tissue is definitely present first in the lobule and second in the duct. The glandular tissue is present in the lobule. That is nothing but your alveoli, and it is present inside the duct. Right? Important is, if there is a cancer which arises from the lobules, it will be called as lobular carcinoma. Very good. And if there is a cancer which arises from the ducts, which will be called as a ductal carcinoma. Now, that's the first thing. Second important thing you have to remember, if the cancer only grows along the basement membrane, if the cancer only grows above the basement membrane, such type of a cancer bache is known as a carcinoma in situ. When the cancer only grows above the basement membrane, is the cancer growing below the basement membrane? Is it invading the basement membrane? No. So if the cancer only grows above the basement membrane, you have to remember this type of a cancer is known as carcinoma in situ. Okay, you have to remember this. Okay, important is, so if it is a cancer which arises from the lobule and only grows along the basement membrane, can I call it LCIS, that is lobular carcinoma in situ? Yes, it is called as LCIS, lobular carcinoma in situ. Next important is, if the cancer arises from the duct and it grows only along the basement membrane, it does not invade the basement membrane, such type can be called as DCIS. What is DCIS? Ductal carcinoma in situ. Ductal carcinoma in situ. Okay. Next is the variety of cancer where the cancer actually invades the basement membrane. It is going to invade, it is going to damage the basement membrane and it is going to grow inside. Such type of a cancer bache which grows inside the basement membrane also is called as the invasive breast cancer. It is called as the invasive carcinoma. Important is, if such type of invasive cancer arises from the lobule, it will be called as invasive lobular carcinoma, and if such type of cancer arises from the ducts, it will be called as invasive ductal carcinoma. Got it? This is the basic classification you have to understand. Ductal या lobular carcinoma हो सकता है. It can be carcinoma in situ or it can be invasive cancer. ठीक है? These are the various types of breast cancer. Important is बच्चों, what is the most common type out of all of them? So you have to remember that the most common type out of all of them is actually the IDC. What is IDC? Invasive ductal carcinoma. The most common type is actually invasive ductal carcinoma. There are multiple types of invasive ductal carcinoma, but the most common type which is there, it is actually NOS. What is NOS? Not otherwise specified. जो किसी भी category में नहीं आता, that is the most common type. Sorry. Okay, so please remember, invasive ductal carcinoma which is there, it is the most common type of breast cancer. Yes, IDC, invasive ductal carcinoma, is the most common type of breast cancer. Now, there are various types of this invasive ductal carcinoma. You have to remember the tubular variety which is there, it has the best prognosis or the best outcome. Invasive ductal carcinoma can be of various types. The tubular variety will have the best prognosis, whereas the medullary variety which is there, it will have the worst prognosis. The medullary variety which is there, bacho, it is going to have the worst prognosis among all types of invasive ductal carcinoma. Okay? If I talk about the invasive lobular carcinoma, this is not ductal bache, this is invasive lobular carcinoma. Now if I talk about the invasive lobular carcinoma now, invasive lobular carcinoma mein you have to remember the gene mutation. So this has been a previous year question, both of these. The gene mutation which is seen in an invasive lobular carcinoma is known as E-cadherin gene mutation, bacho. It is actually called as the E-cadherin gene mutation. So please be aware of this fact that invasive lobular carcinoma can occur due to E-cadherin gene mutation. Next important you have to be aware of it is that on histopathological examination, which kind of appearance is usually seen in a patient of invasive lobular carcinoma. If it is a case of ILC, invasive lobular cancer, can you see in this the malignant cells which are there, they are actually piled up one behind the another. एक के पीछे एक है definitely. They are standing in a single line. Okay. Therefore, this looks like ना as if the files are kept in an Indian government office. India के government offices में ऐसी files रखी जाती है. Therefore, this is classically called as the Indian file pattern or the single file pattern. ठीक है? So please remember, you have to remember बच्चे that on histopathological examination in a patient of invasive lobular carcinoma, image has also come in the examination, and direct question has also come. How does the histopathological examination looks like? It is called as the single file pattern. It is known as the single file or the Indian file pattern. It is known as the single file or the Indian file pattern. Okay, it is known as the single file or the Indian file pattern. कोई दिक्कत नहीं है इसमें. Hopefully that's easy for you to understand. ठीक है? This has been a previous year question बच्चों. So please be aware of this. ठीक है? Important is now, if I talk about LCIS, what is LCIS? So you have to remember LCIS is actually lobular carcinoma in situ. Okay? LCIS is nothing but lobular carcinoma in situ, and in lobular carcinoma in situ, previously it was considered as a malignancy. Yes, pehle it was called as a malignancy, but now according to the recent 8th AJCC update, it is not anymore considered as a malignancy. Yes, lobular carcinoma in situ, we have seen that it does not grow like a cancer, it is just a benign lesion almost. Okay, so nowadays we have to remember that LCIS which is there, that is your lobular carcinoma in situ, will be considered as a benign lesion. Henceforth you have to remember that LCIS which is there, it is not a malignancy, it will be considered as a benign lesion. Please remember that. So therefore in this condition we will just go for observation and follow up. If there is a patient who is having a lobular carcinoma in situ on biopsy, in this patient definitely we will only go for observation and follow up. ठीक है, तो तुम बोल रहे होंगे sir, like this is the important update that you have to remember. Second thing that I want to highlight again is, why did I say that FNAC is not a better choice but true cut biopsy is a better choice? Can you understand it now? Because on FNAC you are only getting cells. On that you can just tell whether the patient is having a cancer or not. But on biopsy definitely bache, you are getting the basement membrane, also you are getting the whole tissue. And on biopsy, as you get the whole tissue, it will be easy, okay, it will be easy for you to tell whether the patient is having an invasive cancer or the patient is having any kind of invasive cancer or only a carcinoma in situ. Please remember. So it is invasive lobular carcinoma and invasive ductal carcinoma. Okay, so that's the important thing. कोई दिक्कत नहीं है बच्चों. Now let's talk about the molecular classification of breast cancer. Because why molecular classification of breast cancer is important? Because I've told you that breast cancer is a special type of cancer in your body which can be treated with hormonal therapy. But for that, definitely you have to first of all see that whether your breast cancer cells do have these hormonal receptors on their surface or not. उनके सरफेस पे अगर हार्मोनल रिसेप्टर्स ही नहीं होंगे बच्चों, तो ऐसे वाले कैंसर को तुम हार्मोनल थेरेपी से ट्रीट कर पाओगे क्या? नहीं कर पाते. दैट इज द रीजन. सो यू हैव टू रिमेंबर बच्चे दैट मॉलिक्यूलर क्लासिफिकेशन इज इंपॉर्टेंट फॉर अ ब्रेस्ट कैंसर टू नो वेदर वी कैन ट्रीट द ब्रेस्ट कैंसर विद द हेल्प ऑफ अ hormonal therapy or not. So let's see about the molecular classification. Okay, if I talk about the molecular classification, first of all, for example, if we have done the biopsy, we have done a histopathological examination, then they do a immunohistochemistry, and on that immunohistochemistry definitely, okay, they are going to identify the receptors which are present on the surface of these cancerous cells. ठीक है, immunohistochemistry IHC. ठीक है. Second, now according to the presence of receptors on the surface of the breast cancer bacche, definitely these are classified into various types. First is the luminal A, second is the luminal B, third luminal B majority of the cases, then third we have the luminal B some minority cases of luminal B, and last is the basal type. ठीक है, last is the basal type. Important is we are going to check for which receptors on the surface of the breast cancer cells. We are going to check for the presence of ER is what? Estrogen receptor, whether the estrogen receptors are present or not. Then we are going to check for PR. What is PR? Progesterone receptors. Okay, we are going to check for the presence of progesterone receptors. And then we are also going to check for HER2 new receptors. HER2 या new receptors. ठीक है, we are going to check for the presence of HER2 new receptors. And then we are also going to check for a Ki67. What is this Ki67 बच्चे? Ki67 is nothing but proliferation marker. Ki67 is nothing but a proliferation marker which is there. What do I mean by proliferation marker? That means it will tell us about the activity, or it will tell us about the activity of the breast cancer. If the cell proliferation or the proliferation in the breast cancer is more, definitely the activity of the Ki67 will be high. And if the proliferation in the breast cancer is less, definitely the activity of the Ki67 will be low. No issues with this anybody? That's the important thing. If I talk about luminal A बच्चों, luminal A is what? You have to remember, luminal A means ER positive होता है उसमें, PR positive होता है उसमें, but HER2 new negative होता है. ठीक है, it is ER positive, PR positive and HER2 new negative. What do I mean by this? Estrogen and progesterone receptors will be present on the cells, but HER2 new receptors are negative. So if this is a breast cancer, that will be called as luminal A. That is what is known as luminal A, definitely. ठीक है, so that has to be remembered बच्चे. Important is in this condition, in luminal A, you have to remember the index, the proliferation marker index जो होता है ना, वो low होता है. In the Ki67 activity which is there in luminal A is very very low. That has to be remembered. Next important, if I talk about the luminal B majority. ल्यूमिनल बी मेजॉरिटी केसेस में क्या होता है, यू हैव टू रिमेंबर इट इज ट्रिपल पॉजिटिव. व्हाट डू आई मीन बाय ट्रिपल पॉजिटिव? इट इज ER पॉजिटिव, PR पॉजिटिव, HER2 न्यू पॉजिटिव. ठीक है, सो डेफिनेटली ER एस्ट्रोजन रिसेप्टर्स विल बी प्रेजेंट, प्रोजेस्टेरॉन रिसेप्टर्स विल बी प्रेजेंट, एंड HER2 न्यू रिसेप्टर्स विल आल्सो बी प्रेजेंट. ठीक है, एंड डेफिनेटली द Ki-67 activity is going to be low. Ki-67 activity will be low. ठीक है, नेक्स्ट इंपॉर्टेंट इज ल्यूमिनल बी माइनॉरिटी. ल्यूमिनल बी माइनॉरिटी में क्या होता है, इट इज सेम एज ल्यूमिनल ए. यस, इट इज सेम एज ल्यूमिनल ए, मतलब इट विल बी ER पॉजिटिव, इट विल बी PR पॉजिटिव, इट विल बी HER2 न्यू नेगेटिव. So you will say, sir, if it is same as luminal A, then definitely why we were classifying it differently? बच्चे, because you have to remember in this condition the Ki-67 or the proliferation marker activity will be very very high. ठीक है, तो याद रखना, in this definitely the proliferation marker activity is high. Therefore, minority cases of luminal B which are there, they are considered as ER positive, PR positive, HER2 new negative, and their activity of the Ki-67 will be high. The next one, the last one you have to remember is the basal type of breast cancer. In basal type of breast cancer, please remember it is a triple negative breast cancer. Triple negative, ठीक है, TNBC I'll call it. That is a triple negative breast cancer. And if it is a triple negative breast cancer, you have to remember that means it does not have any estrogen receptors, ER negative, no progesterone receptors, PR negative, no HER2 new receptors, so HER2 new negative. So ER negative, PR negative, HER2 new negative type of a breast cancer is what is called as a basal type or a triple negative breast cancer. ठीक है, and here the proliferation marker activity is very very high. Here the proliferation marker activity is very very high. Now important is, if they ask you which is the most common subtype according to this molecular classification, so you have to remember the most common subtype will be luminal type A. The most common subtype is going to be luminal type A. Okay, whereas you have to remember another important thing, that luminal type A, as it has a low proliferation marker, definitely these cells are dividing but less rapidly, and therefore it will have the best prognosis. So if they ask you among the molecular classification which type of breast cancer has the best prognosis, so you have to remember it is the luminal type A which has the best prognosis. ठीक है, no issues with this anybody, please remember this. ठीक है, so most common subtype is going to be the luminal type A, and it will also have overall the best prognosis. Please remember this. ठीक है, याद रखना ये बात. Next important is worst prognosis. Worst prognosis मतलब, see, if it is a triple negative breast cancer, no ER receptor, no PR receptor, and no HER2 new receptor, can you treat such type of a breast cancer with hormonal therapy? No. So you have to remember that the triple negative breast cancer or the basal type of breast cancer cannot be treated with hormonal therapy. Okay, and this type of a breast cancer will have the worst prognosis. Previous year question it will have the worst prognosis. So triple negative breast cancer, okay, will have the worst prognosis. That has to be remembered. Most common and best prognosis is definitely luminal type A. Worst prognosis is the basal type, which is having the worst prognosis overall. Triple negative breast cancer. ठीक है, तो याद रखो बच्चे, depending on the presence of the receptors on the surface of the breast cancer cells, we are going to classify the breast cancer according to the molecular classification based on immunohistochemistry. Important is luminal A will be ER positive, PR positive, HER2 negative, and the activity will be low. Second is luminal type B. Majority of the cases will be triple positive, that is ER positive, PR positive, and HER2 new positive, and the proliferation activity is low again. Next is luminal type B. Minority cases, they are same like luminal type A, that is ER positive, PR positive, HER2 new negative. But important is, here the proliferation activity is very very high. That means this cancer is very very rapidly dividing. And last is basal type, that is triple negative breast cancer. Triple negative breast cancer means ER negative, PR negative, HER2 new negative, and as it is triple negative, no receptors for hormones on their surface, therefore they cannot be treated. These basal type of breast cancer cannot be treated by hormonal therapy, and therefore they are having the worst prognosis. Got it बच्चे? So you have to remember this. ठीक है, कोई दिक्कत नहीं है इसमें. Hopefully you have understood this. ठीक है, चलो. Now if I talk about the TNM staging of a breast cancer, is TNM staging important for all cancers of your body? No. TNM staging is not important for all cancers of your body. You have to remember it's important break you want? Let's complete the classification staging once definitely, and then before management we can take it. Okay. So एक बार staging कर लेते हैं. Staging is easy. Yeah. Okay. So important is if I talk about the TNM staging. If I talk about the TNM staging of your breast cancer, बच्चों, then definitely याद रख लो, there are 3 cancers of your body जहाँ पे तुम्हें staging याद रखनी है. In your examination that is important. Why? Because please remember these 3 are the cancers where the staging will decide the treatment, where the staging is going to decide the treatment. Okay, what are those? First is the breast cancer of surgery, second is the laryngeal cancer of ENT, and third is the cervical cancer of obs-gynae. And these were the same 3 cancers on which questions have been asked on staging in the Jan 2023 examination. ठीक है, these are the cancers जिस पे usually question आता है. Thyroid cancer की staging पे commonly questions नहीं आते हैं. थायराइड कैंसर की स्टेजिंग से हम ट्रीटमेंट डिसाइड नहीं करते. इट्स ऑलवेज टोटल थायराइडेक्टमी. दैट इज द रीजन. स्टेजिंग जिसके कैंसर से लाइक ट्रीटमेंट जिसके स्टेजिंग से डिसाइड होती है, दैट इज व्हाट इज द इंपॉर्टेंट स्टेजिंग. ठीक है, दैट यू हैव टू रिमेंबर. नेक्स्ट इंपॉर्टेंट इफ आई टॉक अबाउट टीएनएम स्टेजिंग बच्चों, टीएनएम स्टेजिंग वेयर टी यूजुअली स्टैंड्स फॉर व्हाट? टी यूजुअली स्टैंड्स फॉर द ट्यूमर साइज. ओके, व्हाट इज द साइज ऑफ द ट्यूमर? दैट इज व्हाट डिसाइड्स यूजुअली द टी स्टेजिंग. सेकंड इंपॉर्टेंट, T staging is not only decided by the tumor size, but it can also be decided by the number of structures which are involved. If the number of structures involved are more or less, depending on that also you can decide your T staging. And third, it can also be decided by the depth of invasion. There was a recent question in July 30th examination. I'll be talking about it in GIT also. याद रखना, in GIT wall definitely we have what? Mucosa, submucosa, muscularis and serosa. So important is in GIT cancers, the T staging or the tumor staging is decided by the invasion or by the depth of invasion usually. How many layers have been involved? Whether it is only mucosa or submucosa or muscularis or serosa. ठीक है? Depending on the depth of invasion also we can decide the T staging. Please remember. हाँ, TNM मैं बोल रहा हूँ. TNM dependent cancer. Okay, जिनकी staging पूछी जाती है. Breast cancer, CA larynx, cancer larynx and your cervical cancer. 3 of them. So T for tumor size बच्चे definitely. So tumor size, or it can be the number of structures involved, or it can be the depth of invasion. N goes for what? N goes for the nodal metastasis. What do I mean by this nodal metastasis? That means the number of lymph nodes involved. The number of lymph nodes involved, that decides the nodal staging of a cancer. And last is M. M goes for what? M goes for distant metastasis. M goes for distant metastasis. So you have to remember definitely distant metastasis, that means spread or metastasis to a distant or another organ. So depending on that, it will decide the M staging. ठीक है? So please remember this बच्चों. That's important. Now if I talk about the TNM staging, let's start with the T staging first. TX अगर लिख के आता है, if the pathologist writes TX, TX का मतलब the tumor cannot be assessed. Okay, the tumor cannot be assessed. Maybe the sample was not sufficient enough to assess the tumor. ठीक है? So TX मतलब tumor cannot be assessed. T0 मतलब there is no tumor. Yeah, T0 मतलब there is no tumor. It is just a collection. It is not a tumor actually. ठीक है? TIS. What is TIS? IS का मतलब in situ. So TIS मतलब it is actually a carcinoma in situ. Okay, when they write TIS, in IS का मतलब होता है in situ. Okay, that is suggestive of DCIS, that is ductal carcinoma in situ or Paget's disease of the nipple. Yes, just like bone, we also have a Paget's disease in the nipple. I will be talking about that later on. So remember that TIS is actually कौन सी staging? DCIS and also Paget's disease of the nipple. Important is LCIS बच्चे, as I've told you now, LCIS is not a part of TIS. Reason is because we do not consider lobular carcinoma in situ as a malignancy now. We consider it to be a benign lesion. That is the reason. ठीक है? LCIS is not a part of the staging. ठीक है? याद रखना ये बात. T1 is what? T1 when the size of the tumor. T1 when the size of the tumor is less than equal to 2 centimeter. T1 when the size of the tumor is less than equal to 2 centimeter. T2 मतलब the size of the tumor is more than 2 centimeter but less than 5 centimeter. Size of the tumor is more than 2 centimeter but less than equal to 5 centimeter. Directly 5 याद रख लो, easy रहेगा. If T3, if I talk about T3, it is any cancer which is more than 5 centimeters in size. T3 मतलब the cancer which is more than 5 centimeters in size. And This was about the size. ठीक है, so T1 less than equal to 2 centimeter, T2 2 to 5 you can say, T3 more than 5 centimeter. No issues with this anybody? It's easy. Yes. Now if I talk about the T4, T4 is T4A, T4B, T4C and T4D. तो T4A की अगर मैं बात करूं, you have to remember T4A मतलब involvement of the chest wall. Okay, T4A मतलब actually involvement of the chest wall. Now what do we consider as the involvement of the chest wall? Involvement of which layers? Do we consider involvement of pectoralis major muscle or pectoralis minor muscle as involvement of chest wall? No. Please remember, yes. Pectoralis major or minor muscle जो होती है बच्चों, it is commonly involved in a breast cancer. So it is not considered as a separate staging. उसको separate staging के तौर पे नहीं देखा जाता है. So please remember, you have to remember involvement of chest wall. That means either involvement of the ribs or the muscles which were present between the ribs. That is your intercostal muscles. Or it is involvement of the boxers, that is your serratus anterior muscle. ठीक है, so please remember involvement of chest wall, that means definitely involvement of the ribs, definitely involvement of the intercostal muscles and involvement of the serratus anterior muscle. Pectoralis muscle is not considered over here. ठीक है, so you can write somewhere over here. यहाँ जगह नहीं है. Pectoralis is not considered as the involvement. Pectoralis muscle involvement is not considered as चेस्ट वॉल इन्वॉल्वमेंट. याद रखना है बात. ठीक है, नेक्स्ट इंपॉर्टेंट यू हैव टू रिमेंबर बच्चे T4B. T4B दैट मींस इन्वॉल्वमेंट ऑफ द स्किन. ठीक है, T4B इज नथिंग बट इन्वॉल्वमेंट ऑफ द स्किन. ठीक है, एंड इफ आई टॉक अबाउट इन्वॉल्वमेंट ऑफ स्किन, व्हाट इज कंसिडर्ड एज द इन्वॉल्वमेंट ऑफ स्किन? सो यू हैव टू रिमेंबर इन्वॉल्वमेंट ऑफ स्किन का मतलब either if there is a PUD orange which is seen. A recent exam question also was there. Okay, PUD orange and a very classical and a commonly repeated question of your exam. That is PUD orange. ठीक है, PUD orange is nothing but orange peel-like appearance of the breast skin. I'll talk about that. So PUD orange is definitely considered as skin involvement. Second, definitely if there is any ulceration of the skin. Yes, ulceration of the skin is considered skin involvement. And lastly, nodules. Okay, if there are any presence of nodules over the skin, it is also considered as skin involvement. Which nodules? Satellite nodules usually they will say. Okay, that means for example, I'll write properly. For example, this is the main breast cancer and there are some nodules out here. That will be called as satellite nodules. So if there is presence of satellite nodules on skin, that is also considered as the skin involvement itself. That is also considered skin involvement. That is T4B. Next bachcho that you have to remember is definitely T4C. What is T4C? It is both. T4C is both, that is nothing else but T4A, that is involvement of the chest wall, plus T4B, that is involvement of the skin. So if chest wall and skin both are involved बच्चों, definitely that is what is called as T4C both. ठीक है, and lastly T4D क्या होता है? T4D is known as inflammatory breast cancer. T4D is known as the inflammatory breast cancer. And if I talk about the T4D or the inflammatory breast cancer, you have to remember definitely this inflammatory breast cancer बच्चे, यहाँ पे it is going to have the worst prognosis. Worst prognosis among the T staging will be seen with T4D. Obviously last staging जो है उसमें worst prognosis आएगा. So you have to remember worst prognosis is definitely seen with T4D, that is your inflammatory breast cancer. In inflammatory breast cancer there is actually a diffuse inflammation over the skin of the breast. पूरे breast के skin पे there's a lot of inflammation. Okay, so that is the classical feature which is seen in a T4D, that is inflammatory breast cancer. And in inflammatory breast cancer we can even take a skin biopsy. Yes, we have to even take a skin biopsy in the patient along with the breast biopsy. No issues with this anybody? That has to be remembered. Okay, so this was easy. T1 less than equal to 2 centimeter, T2 2 to 5, T3 more than 5, T4A chest wall, T4B skin, T4C both and T4D inflammatory breast cancer. Worst prognosis. Important है जिसको chest wall और skin में गड़बड़ी होती है, just remember easy thing. Chest wall, C comes first, S comes later. So T4A has to be chest wall, T4B will be skin. ठीक है, so that is the easiest फंडा. फालतू के निमोनिक याद रखने की कोई जरूरत नहीं है. ठीक है, next बच्चों, if I talk about the nodal metastasis, definitely, so N0 का मतलब होता है there is no nodal metastasis. That means no lymph nodes have been involved. Okay, N0 का मतलब होता है no nodal metastasis, no lymph nodes have been involved. Then N1 का क्या मतलब है? N1 means mobile axillary lymph nodes. What did I tell you? 90% of the breast drains into the axillary group of lymph nodes. So therefore you have to remember that most common lymph nodes which will be involved in a breast cancer are definitely going to be the axillary group of lymph nodes itself. So N1 matlab mobile axillary lymph nodes. What do I mean by this? जब भी whenever the cancer spreads to a lymph node, what happens to the size of the lymph node? Definitely the size of the lymph node is going to increase. There will be lymph node enlargement, or we can call it as the lymphadenopathy. Important is, when there will be lymph node enlargement, you will try to palpate the lymph node, and when you try to palpate the lymph node, you will try to check the size. Okay, it will be increased. Second important, you also try to check the mobility, whether you can move the lymph nodes or not. Normally, the normal lymph nodes, can you move them? Yes, we can move the normal lymph node. But sometimes in a cancer, what is going to happen? The lymph nodes will get fixed. We are not able to move them. They get fixed usually. Okay? So if N1 matlab, if the axillary lymph nodes are involved, but they are still mobile, you can move them still. Okay? So axillary lymph nodes are involved, but you can still move them. That is what is N1 बच्चे. N2A का मतलब होता है if there are fixed or matted axillary lymph node. Matted का मतलब क्या? For example, one axillary lymph node is involved, second is involved, third is involved. So all of them are actually combining together. All of them are combining together and forming a large mass. ठीक है? That is what is called as matted, चिपके हुए lymph nodes. ठीक है? So please remember, if there are fixed or matted axillary lymph node, okay, if you are not able to move these axillary lymph nodes, that means it is N2A, matted or fixed axillary lymph nodes बच्चों. ठीक है? Next important you have to remember, it is N2B. N2B का मतलब होता है only involvement of the internal mammary lymph nodes. I've told you 10% of the breast tissue drains into the internal mammary lymph node. So if there is only involvement of the internal mammary lymph nodes without the involvement of, ये बात याद रखना जरूरी है बच्चे, without axillary. ठीक है? If there is only internal mammary lymph node involvement without axillary lymph node, that is called as N2B. क्योंकि अगर दोनों involve होंगे, it will be N3B. ठीक है? So that's the difference. So you have to remember, if there is only involvement of the internal mammary lymph node, it is N2B. If there is involvement of the infraclavicular lymph node, if there is involvement of the infraclavicular lymph node, it is N3A. If there is involvement of both, B for both, okay. So if there is involvement of both, that is N3B, will be internal mammary lymph nodes and axillary group of lymph nodes. Agar axillary as well as the internal mammary group of lymph nodes, both are involved, then it is considered as the stage N3B. And lastly, if there is involvement of the supraclavicular group of lymph nodes, if there is involvement of the supraclavicular group of lymph nodes, it is N3C. ठीक है? So that is the important one. सबसे important इसमें जो याद रखने लायक है बच्चे, N1 obviously because it is axillary group of lymph node, N2A because N1 में it was mobile, N2 में क्या हो जाता है? It becomes fixed or matted definitely. ठीक है? N3B because it is involvement of both. And ये trick याद रखना है कि N2 जो होता है, it is only involvement of the internal mammary, it is not the involvement of axillary, because if there will be axillary also, then it has to become what? Then it is going to become N3B, then it cannot remain N2B. ठीक है? That's the basic idea बच्चे that you have to remember. And lastly, it is the distant metastasis. If it is M0, that means there is no distant metastasis, and if it is M1, that means distant metastasis is present. Okay, so that has to be understood. I'll talk about what is the most common site of metastasis and all, don't worry about that. Next important thing is you have to remember that in a case of early invasive breast cancer, it is a case of early invasive breast cancer means what? Early invasive breast cancer का मतलब क्या? It is actually stage 1 and stage 2 breast cancer. Important again, stage 1 and stage 2 breast cancer are not T1 and T2. This is different. Okay, multiple combinations of T1 multiple combinations of T staging and staging together are will form stage 1, it will form stage 2, it will form stage 3A, 3B, 3C, and it is going to form stage 4. ठीक है? तो staging ये वाली अलग है. The 1, 2, 3, 4 staging ना बच्चे, that is different staging. ठीक है? That is decided by the various combinations. So please remember, early invasive breast cancer का मतलब the cancer is in the early stages. It is actually stage 1 or stage 2. That means either it can be T1 or T2. स्टेज 1 और 2 में कौन से आते हैं कैंसर्स? आइदर इट इज स्टेज 1 either it is stage T1 or it is T2, and it is N0 or N1. Either there is no lymph node involvement or there is at least mobile axillary lymph node involvement. ठीक है? Or there is one condition that is T3 N0. मतलब staging is T3 more than 5 centimeter but no lymph node involvement. Only this T3 N1 will not be considered as early invasive breast cancer. T3N1 will not be considered as early invasive breast cancer. That has to be remembered. Okay, so that's the important thing. Okay, just a minute. T3N1 will not be considered. I'll write over here, better है, याद रखो तुम्हें, ठीक है. Next important is, please remember, if I talk about a locally advanced breast cancer, these locally advanced breast cancers बच्चे are also known as LABC. Locally advanced breast cancer is also called as LABC. LABC or locally advanced breast cancer, it is stage 3A, 3B and 3C. It is stage 3A, 3B and 3C. इसमें कौन से stagings आते हैं? Here it is either stage T3 or here it is either stage T4 with more than equal to N2, more than equal to N2. Okay, more than equal to N2. N2 या उससे ज्यादा अगर हो staging, then that will be considered as locally advanced breast cancer, that is stage 3A, 3B or 3C. Or we can even have T3N1. Okay, we can even have T3N1. No issues with this, anybody? That has to be remembered. T3N1, T4N1. T3 or T4 में N1 होना is a rare finding though, but it can happen at times. So that will be considered definitely in locally advanced breast cancer. Okay? And important is, if it is stage 4, then stage 4 is what is called as an advanced breast cancer. Stage 4 is actually known as advanced breast cancer. Okay? And stage 4 may definitely, it is usually T, just a minute. ठीक है, T4 mainly is usually covered under advanced breast cancer. ठीक है, T4 which is there, that is mainly covered under advanced breast cancer mainly. यहाँ पे थोड़ा T4 आते हैं कुछ stagings और बाकी T4 mainly यहाँ पे आता है. Most important is यहाँ पे it will be M1. यहाँ पे mainly it will be M1. अगर M1 जैसे ही आ जाता है, if M1 comes, it has to be, that means distant metastasis present, it has to be stage 4, it has to be advanced breast cancer. It has to be advanced breast cancer. That you have to remember बच्चे, ठीक है. It has to be a case of advanced breast cancer. भले फिर वो T1 हो, but if M1 is present, it has to be a advanced breast cancer. Metastatic breast cancer is always advanced stage 4 breast cancer, and here the management will be different. Here we cannot treat the patient by any surgery, by any radiotherapy or any kind of other treatment. Here always the patient is treated by palliative care. That means we only try to improve the survival rate of the patient. बस patient जब तक जिंदा है उसकी लाइफ अच्छे से कटे. Okay, so we try to increase the survival rate of the patient. We try to decrease the size of the tumor with the help of chemotherapy usually. ठीक है, that is what is done in the palliative care. That is what is done in the palliative care, nothing else. ठीक है, no radical treatment will be done in advanced stages. ठीक है, so that has to be remembered. Now if I talk about this, what is this बच्चों? This is what is the classical PUD orange. ठीक है, that is the orange peel like appearance of the skin. ठीक है, so this is important. This is known as PUD orange. संतरे के जैसी skin लग रही है ना, so that is PUD orange बच्चों. So this PUD orange you have to remember definitely. It is orange peel like appearance. It is nothing but orange peel like appearance of skin over breast. It is orange peel like appearance of skin over the breast. What is the cause of it? This has been a very common question. Why the patient has this PUD orange? What is the cause behind this? So you have to remember, it is due to actually blockage of the subdermal or the subcutaneous lymphatic. Skin के नीचे जो lymphatics होते हैं, when they get blocked due to the cancer, that is the reason the patient is going to have this classical PUD orange. So please remember, it is due to, this has also been asked. The cause has also been asked in our examination. So it is due to blockage of subdermal or subcutaneous lymphatics. Please remember another option. It was confusing because another option was dermal or cutaneous lymphatic. So please remember, it is not due to dermal or cutaneous lymphatic. It is due to subdermal or subcutaneous lymphatics. Okay. So due to blockage of the subdermal or subcutaneous lymphatics by the breast cancer, the patient is going to develop what? The patient is going to develop PUD orange. The patient is going to develop PUD orange. Important is, PUD orange will be which stage of the breast cancer? So you have to remember, PUD orange is usually T4B. Why? This has also been a twice asked exam question in your examination. So please remember, bache, PUD orange which is there, it is T4B, because we know that PUD orange is considered as skin involvement, right? We know that the PUD orange is considered as skin involvement. Therefore, T4B will be the staging for your PUD orange. That has been a previous year question. Okay? Next, which is there over here. What is this? Here, can you see there are a lot of small nodules which are seen all over the skin. Okay, and here actually the patient has a history of breast cancer. Now, that breast cancer was treated already, but now it has again appeared. Okay, and now it is spreading into all the cutaneous lymphatics. So this is called as the cancer and cuirass. This is what is called as the cancer and cuirass, bache. and this cancer in cuirass which is there. Just a minute. This cancer in cuirass which is there, bacho, you have to remember this cancer in cuirass is suggestive of a local regional recurrence. Okay, that means you have already removed the breast cancer, but then it has again reappeared and now it is spreading into the cutaneous lymphatics of the skin, bache. Therefore, this is what is called as a cancer in cuirass, which is suggestive of a loco-regional recurrence. Okay, so that has to be remembered. Next important, if I talk about, is this. What is this? Can you see the nipple has been pulled inside? And if the nipple is pulled inside, bache, it is known as nipple retraction. If the nipple is pulled inside, that is what is called as nipple retraction. For example, if this is your breast cancer, breast tissue, okay, and I've told you what opens at the level of nipple. At the level of nipple, a lot of lactiferous ducts are going to open. A lot of lactiferous ducts are going to open. But if the cancer is actually involving, this lactiferous ducts, what is going to happen? These lactiferous ducts, due to the cancer and fibrosis, they are going to pull the nipple inside, and that is what is causing this nipple retraction. So nipple retraction, question aata hai, it is due to involvement of which structure? So please remember, it is due to involvement of the lactiferous ducts in a patient of breast cancer. It is due to involvement of lactiferous ducts by the cancer. No issues with this. It is due to involvement of the lactiferous ducts by the cancer. Next important is this one. क्या दिख रहा है यहाँ पे? Can you see? यहाँ पे तो nipple अंदर जो गई थी. यहाँ पे the nipple is absolutely fine, but the problem is the skin has been pulled inside. And if the skin is pulled inside, there is skin retraction, बच्चे. This skin retraction is what is known as dimpling or puckering. Okay, this skin retraction which is there, it is actually called as dimpling or puckering. Important is, if I talk about dimpling or puckering of skin, it is due to involvement of which structure? For example, see, this is again the breast tissue, and we have already discussed, definitely there were some ligaments inside the breast which were supporting the breast tissue. Which were those breast tissue, bache? Definitely the breast, which were those ligaments? Those ligaments definitely which were extending from the pectoralis fascia till the skin of the breast. This was actually your suspensory ligaments of Cooper. So when the cancer is going to involve the suspensory ligaments of Cooper, these suspensory ligaments of Cooper are going to pull the skin inside, and that is what is called as dimpling or puckering. So you have to remember, dimpling or puckering is due to involvement of what? So please remember, it is due to involvement of the suspensory ligaments of Cooper. It is due to involvement of suspensory ligaments of Cooper. No issues with this, anybody? It is due to involvement of suspensory ligaments of Cooper. Okay? So that's the important thing. Please remember this. These are the important things that you have to be aware of. Okay? क्या involve होता है, that is more important to be remembered. Now second important thing is, please tell me, will you consider that nipple retraction and dimpling and puckering to be skin involvement? तुम nipple retraction और dimpling और puckering को skin involvement मानोगे क्या बच्चों? Please tell me that. Will you consider nipple retraction and dimpling or puckering as skin involvement? Please tell me. इन दोनों को skin involvement माना जाएगा क्या? No. Very good. So please remember, both these conditions, whether it is nipple retraction or whether it is your dimpling or puckering, it is not considered as skin involvement. You have to remember, it is not considered as skin involvement. Okay, it is not considered as skin involvement because here the skin is not involved, bache. Here the cancer is not involving the skin, but it is actually involving another structures जिसकी वजह से you are actually seeing the features on the skin. Okay, so therefore both of these are not considered as skin involvement. Both of them cannot be T4B. ठीक है, both of them cannot be T4B. ये याद रखना बस. ठीक है, so that's more important. So now we will be talking about the management of breast cancer. Okay, and then some important conditions or tumors of the breast cancer. Breast. ठीक है. So if you want your break, let's take a break then. क्योंकि management is important. I'll try to summarize all the management in one table and then we'll be describing it also. Don't worry about that. Okay, chalo. 15 minutes का break ले लो, then we'll join back again. Now hopefully it's audible बच्चे. Now hopefully it will be audible. ठीक है, चलो let's start. Okay, let's start with the management of your breast cancer. We have spoken about the three varieties of breast cancer depending on the staging of breast cancer. Stage 1 and stage 2 will be considered as early invasive breast cancer. Stage 3 A, B, C will be considered as stage locally advanced breast cancer, LABC, and stage 4 will be considered as advanced breast cancer. The management will be different for all these types. You have to remember that. First of all, if I talk about the early invasive breast cancer, you have to remember for early invasive breast cancer, bachcho, the treatment is always a surgery. And as why the treatment will be surgery? Because the cancer will be limited to a specific quadrant only. That is the reason here we can just go for a surgery. Okay, it can be a BCS. What is BCS? Breast conservation surgery. Now, what do I mean by conservation? Save. Why? Because we are trying to save majority of the breast tissue. Okay, we are only trying to remove the lump or the quadrant which is affected. We are not trying to remove the whole breast. That is the reason why we are trying to save breast over here. Therefore, it is known as BCS. That is your breast conservation surgery. Important is, bachcho, if I talk about the breast conservation surgery, one thing I'll talk about that in detail, but over here you have to remember one thing. Whenever we do a breast conservation surgery, it will always and always be followed by a radiotherapy. Why? Because if you are removing only some part of the breast tissue, right, there are very high chances that some of the malignant cells or some of the cancerous cells can be left behind. Yes, therefore to prevent any recurrence कि वापस से ना cancer हो जाए, for that purpose you have to always give a radiotherapy after a breast conservation surgery. Okay, so breast conservation surgery followed by radiotherapy. Breast conservation surgery followed by radiotherapy will be one of the treatment options that you have for an early invasive breast cancer. Next important, बच्चे, after BCS, if BCS is not possible, why it is not possible, I'll talk about that. Okay, in that condition, if BCS is not possible, we can even go for a simple mastectomy. If BCS is not possible, we can go for a simple mastectomy. Now, what is ectomy? I've told you, ectomy means removal. Mastectomy means removal of the breast. And simple mastectomy, matlab, we are only removing the breast tissue. We are not removing the lymph nodes of this patient. Therefore, it is called as simple mastectomy. Got it? So, that's the important thing. Now, if it is a locally advanced breast cancer, in locally advanced breast cancer, please remember, here first of all, the cancer is large in size. Therefore, first thing is we try to decrease the size of the cancer. We try to decrease the size of the tumor. And for decreasing the size of the tumor, before going for a surgery, बच्चों, we have to give chemotherapy to the patient. ठीक है? याद रखना एक बात, when we give chemo before surgery, to the patient or any treatment which is given before surgery, it is called as neoadjuvant. ठीक है? So please remember, any treatment which is given before surgery, it is called as a neoadjuvant treatment. For example, before surgery, if we give chemotherapy, that should be called as a neoadjuvant chemotherapy. If we give radiotherapy before surgery, that is called as neoadjuvant radiotherapy. ठीक है? So that is important. Any treatment which is given before surgery will be called as neoadjuvant, and any treatment which is given after surgery, that will be called as adjuvant treatment. That will be called as adjuvant. For example, if you are giving radiotherapy after surgery, that is called as an adjuvant radiotherapy. Got it? So that's the important thing you have to be aware of. Now here, as I've told you, first of all, our main aim before surgery is to decrease the size of the cancer. For that, before going for a surgery, we give chemotherapy to the patient. And as we are giving chemotherapy prior to surgery, this should be called as a neoadjuvant chemotherapy. So we'll start with a neoadjuvant chemotherapy. Once the size of the cancer is reduced, then we go for a MRM. What is a MRM? I'll talk about that. MRM is nothing but a modified radical mastectomy. You have to be aware of that fact. Just ठीक है? So chemotherapy के बाद we have to go for a MRM, modified radical mastectomy, and once we are done with the surgery, modified radical mastectomy, then we have to follow it up with radiotherapy again. Why radiotherapy here also? Because we know already, if it is a cancer and it is large in size, it has spread to the lymph nodes, there is a very high chance that there will be a recurrence. So therefore after surgery better go for a radiotherapy. ठीक है. Important is MRM, modified radical mastectomy. Radical का मतलब we are not only removing the breast tissue but we are also removing the lymph nodes and the other structures which are involved in the vicinity of the breast or in the surrounding of the breast. ठीक है. So that's the important thing. So locally advanced के लिए it is neoadjuvant chemotherapy, MRM followed by radiotherapy. ठीक है. Then if it is a ER/PR positive, उसके पहले advanced के लिए लिख लेना कहीं. Just a minute, I'll write somewhere over here. I'm writing over here for advanced breast cancer, बच्चों. Please remember, for an advanced breast cancer, the treatment will be what? For an advanced breast cancer, the treatment is going to be only palliative care. For an advanced breast cancer, the treatment is going to be only palliative care. In palliative care, we mainly give chemotherapy to the patient. In palliative care, we mainly give. Sometimes radiotherapy can also be given, but mainly it is the chemotherapy which is given to the patient. Got it? So please remember, bache, that for advanced breast cancer in stage 4, we only give a palliative care. Palliative care is nothing but a supportive care which will only help in increasing the survival rate of the patient. Okay? Jitna bhi time bacha hai patient ke paas, that will be improved. Okay? The patient will have a better quality of life in that time. So that's the important thing. Next is definitely ER/PR positive breast cancer. Now I've already told you, if the ER and PR, that is estrogen and progesterone receptors, are present on the breast cancer surface, definitely such type of breast cancer can be treated with hormonal therapy. So here definitely my treatment plan will be hormonal therapy. I can treat the patient with some drugs. Important is which hormonal therapy will be given. So we have to see whether the patient is a premenopausal female or she is a postmenopausal female. Okay? So if I talk about a premenopausal female, okay? Premenopausal female means that you have to understand the patient who has not attained the menopause yet. The patient who is still in the reproductive age group. अभी तक menopause नहीं हुआ, अभी भी menses चल रहा है ऐसे patient. So that is a premenopausal female. Now, bache, please tell me, in this premenopausal female, the main source of estrogen. Why? Estrogen आएगा तभी तो breast cancer की growth होगी. So definitely, what is the main source of estrogen in a reproductive or a premenopausal age group female? The main source of estrogen is definitely your ovaries, right? The main source of estrogen is definitely your ovaries. And then that estrogen is going to come, it is going to stimulate the breast, and therefore there will be more proliferation in the breast, causing increased size of the breast cancer, right? Therefore, we need some drugs which are going to block the estrogen receptors. As I've told you, we need some drugs which will block the estrogen receptors so that the estrogen cannot act on the breast, and therefore we will stop the growth of the breast cancer. Problem is, if we give estrogen antagonist, if we are going to give estrogen antagonist, they are going to block all the estrogen receptor. Does estrogen only act on the breast? No, estrogen also acts on the bone. So अगर bone पे action stop हो गया, patient will have osteoporosis. Estrogen also acts on the uterus in the endometrium. So endometrium पे अगर action stop हो गया, the patient will have endometrial atrophy and the patient will not get any kind of menses. Okay, so if the patient wants to conceive or the patient wants to have a child, she cannot have a child over there. Okay, so that is the problem. So here you have to remember, therefore in this patient we should give some drugs which will be agonist at some site and antagonist at some site. Matlab, they will stimulate estrogen at some site and they will block the estrogen at some site. Okay, what are these drugs called as? These drugs are called as SERMs. What is SERM? Selective estrogen receptor modulator. We are not calling them agonist or antagonist because they have different actions at different organs. Okay, therefore here we are going to give SERMs to the patient, that is selective estrogen receptor modulator. And ये जो selective estrogen receptor modulator होता है, the best drug that we give in a case of breast cancer is usually tamoxifen. Okay, it is usually tamoxifen. See, tamoxifen is commonly used. The other drug which can be used is raloxifene. Okay, now important is, what is the difference between tamoxifen and raloxifene? Tamoxifen, which is there, bacho, it is agonist, okay, at the level of the endometrium and antagonist at the level of the breast. That means it is going to block the estrogen receptors at the level of the breast. As it blocks the estrogen receptors at the breast, definitely estrogen cannot act on the breast and therefore the size of the tumor starts decreasing. Therefore, it is useful in breast cancer patients. But it is agonist on the endometrium. That means it will stimulate the endometrium and that will cause more proliferation of the endometrium. And if there is more proliferation, more division inside the endometrium, the patient will have endometrial hyperplasia. If the patient has endometrial hyperplasia, the patient can further progress into endometrial cancer. Yes. So you have to remember that tamoxifen, which is there, bache, it is very good drug, but the problem is it is associated with endometrial cancer. Second is raloxifene. Raloxifene जो होती है बच्चे, it has a antagonistic action. It has an antagonistic action on the breast. मतलब it will block the receptors of estrogen on the breast. So it will decrease the size of breast cancer. But second important, it will not have any action on the endometrium. मतलब on the endometrium is neither an agonist nor an antagonist. Endometrium pe neither it is an agonist nor an antagonist. Therefore, it will not increase the risk of endometrial cancer. Raloxifene. Problem is, raloxifene which is there, it is not so efficacious as tamoxifen. The decrease in the incidence of breast cancer has been very good with tamoxifen, but raloxifene इतनी effective drug नहीं होती है. So therefore, still we prefer tamoxifen even if there is a risk of endometrial cancer. ठीक है? So that is the important thing. दूसरी drug raloxifene बोल सकते हो, but if they ask you to mark one, answer is always and always you have to remember it is tamoxifen. ठीक है? It is still a better drug. Important is if I talk about the side effects of this group, so you have to remember the side effect of these group of drugs. The most common side effect is not endometrial cancer. Don't mark it as the most common side effect. Please remember it is a rare side effect. Most common side effect is going to be hot flushes. Most common side effect is going to be hot flushes. Due to vasodilation, the patient is going to have hot flushes. The other risk factor which is there, it will be agonist on the blood also. That means estrogen क्या करता है blood में? It causes thromboembolism. Therefore, this tamoxifen will also cause thromboembolism on the blood, and therefore it will increase the risk of deep venous thrombosis in the patient. So it can even cause DVT in the patient, deep venous thrombosis. And lastly, you have to remember it will increase the risk of endometrial cancer by causing endometrial hyperplasia. It will cause endometrial hyperplasia, which will further increase the risk of endometrial cancer. कोई दिक्कत नहीं है बच्चों. That is the important thing. Next, definitely this was about a premenopausal female. Now if I talk about a postmenopausal female, that means the patient who has already attained her menses. The patient who has already attained her menopause, sorry. The patient who has already attained her menopause, that means uske menses khatam ho gaye. Okay. So in a postmenopausal female, what is the main source of estrogen? Now her ovaries are not producing any estrogen. Why? Because menopause ke baad the ovaries undergo atrophy, and therefore there is no estrogen coming from the ovaries. Okay. So there is no problem. Problem is where here the estrogen is actually coming from the aromatase enzyme. We knew now that aromatase enzyme was converting the androgens into estrogen. Yes. So that aromatase enzyme is the criminal over here in a postmenopausal female. All that excess estrogen is coming from that aromatase enzyme. So can we block or can we inhibit that aromatase enzyme? Yes. And for that purpose, in a postmenopausal female, for hormonal therapy, we have to give aromatase inhibitors, drugs like letrozole or anastrozole. Okay? Azole drugs. So please remember here in a postmenopausal female, we have to give aromatase inhibitors. We have to give aromatase inhibitors, drugs like letrozole and anastrozole. Letrozole or anastrozole. The important side effect that you have to remember about this drug, bache, the important side effect that you have to remember about this drug is actually osteoporosis. Reason is they are going to decrease the level of estrogen, that too in a postmenopausal female. Therefore, if there is no estrogen, definitely the osteoblastic action of the bone decreases. And अगर bone forming action कम हो जाएगी, bone टूटना शुरू हो जाएगा. That is what is osteoporosis. Please remember. Therefore, the side effect which is there, it is osteoporosis in a aromatase inhibitor. It is a aromatase inhibitor. The side effect is osteoporosis. No issues with this, anybody? That's the important thing. Okay? Chalo. Now important is, let's talk about the HER2 new positive breast cancer. If the breast cancer is actually having these HER2 new receptors on the surface. So for this HER2 new positive breast cancer, here you have to give chemotherapy to the patient, but along with chemotherapy there is a very special drug which will be given to the patient. And what is that drug? That is a monoclonal antibody. Previous year question it has been, it is called as trastuzumab, or we can also give Herceptin. So the drugs which are given in a case of HER2 new positive breast cancer, it is usually trastuzumab. It is either trastuzumab or we can use Herceptin. Okay? Along with that we have to use chemotherapy. Along with that we have to give chemotherapy to the patient. That has to be remembered. I'll talk about the chemotherapy used for breast cancer, don't worry about that. So please remember, If it is a HER2 new positive breast cancer, it is trastuzumab or Herceptin plus chemotherapy. This table summarizes every important management that you need to know about the breast cancer. Okay? Early invasive BCS followed by radiotherapy or simple mastectomy. LABC, locally advanced breast cancer, neoadjuvant chemotherapy followed by MRM followed by radiotherapy. Advanced breast cancer, I've already told you, it is a palliative care. ER/PR positive breast cancer, premenopausal female, it is so mainly the drug which is used is tamoxifen. Postmenopausal female, it is aromatase inhibitors. Mainly the drug used is letrozole. Okay, and HER2 new positive breast cancer, it is trastuzumab or Herceptin plus chemotherapy. Okay, no issues with this anybody? That is important. Now let's talk about the management further. We'll talk about the surgeries that we have discussed. Okay, if I talk about the first surgery, bache, that is your BCS. What is BCS? Breast conservation surgery. BCS was nothing but breast conservation surgery. I've told you, in breast conservation surgery, we are trying to conserve or we are trying to save the breast. Therefore, we are only going to remove the lump which is there, or we are only going to remove the tumor which is there. Okay? Why do we use aromatase inhibitors in postmenopausal female? Because in postmenopausal female, the only source of estrogen is this conversion. Okay, by the aromatase enzyme. Aromatase enzyme converts androgens to estrogen in the postmenopausal female, and this estrogen is going to act on the breast cancer cells, and therefore there will be more proliferation, and that will increase the size of the breast cancer. But if we block the aromatase enzyme itself, there will not be any production of estrogen now. Therefore, the action on the breast cancer cells will not happen, thereby decreasing the proliferation of the breast cancer cells and thereby decreasing the size of the breast cancer. Got it? That's the important thing. Now, if I talk about the breast conservation surgery, bache, here you have to remember, we are only going to remove the breast lump, and that is what is called as lumpectomy. That is what is known as lumpectomy. And what is the normal margin status? Definitely that we take. Please remember, in breast conservation surgery, lumpectomy is done along with normal margins. Normal margins का status जो था पहले बच्चों, it was 1 centimeter, but the new status which has been told, it is 1 millimeter. Yes. अब हम और कम मार्जिन लेते हैं. फॉर एग्जाम्पल, व्हाट इज नॉर्मल मार्जिन मीन्स? फॉर एग्जाम्पल, दिस इज द कैंसर. ठीक है, वी आर गोइंग टू रिमूव द कैंसर, बट अलॉन्ग विद दैट वी विल रिमूव कम से कम 1 सेंटीमीटर का नॉर्मल मार्जिन. वी आर गोइंग टू रिमूव 1 सेंटीमीटर का नॉर्मल मार्जिन टू अवॉइड any malignant cell to be left inside the breast. ठीक है, to avoid that, always whenever we are only going to remove the cancer or the tumor, we will always take some normal margins. ठीक है, here the normal margin status for BCS, earlier it was 1 centimeter, but now it is only 1 millimeter. Okay, so please remember the margin status which is there. The margin status will be only 1 millimeter. No issues with this anybody? That has to be remembered. Next important is, definitely you have to remember one thing what I told you already. BCS जब भी करोगे, it should always be followed by what? Radiotherapy. That means radiotherapy is always mandatory. ठीक है, so you have to remember that radiotherapy is mandatory, that is compulsory. Okay, radiotherapy is mandatory or compulsory after BCS. Why? To prevent recurrence, कि वापस से कैंसर ना हो, to prevent the recurrence, because chances of recurrence after a breast conservation surgery are high, because we are only removing the lump. Therefore, to prevent the recurrence, radiotherapy is always mandatory. What are the conditions when BCS cannot be done? What are the conditions where breast conservation surgery is contraindicated? Any condition where radiotherapy cannot be done, BCS cannot be done. Why? Because we know that radiotherapy is mandatory. अगर radiotherapy नहीं कर सकते तो BCS कर पाओगे क्या तुम? नहीं. So you have to remember, any condition where radiotherapy is contraindicated, BCS will also be contraindicated itself. Option A, the first one says pregnancy. We know that in pregnancy, can we give radiotherapy to the patient? No. That is the reason breast conservation surgery is usually contraindicated during pregnancy. Okay? Important is that. Second, if the patient has received any prior radiotherapy to chest. Why? What is the reason? If the patient has already received a radiotherapy to the chest, bachcho, definitely if we give again a radiation exposure to the chest, there will be a high risk of secondary malignancy. We are actually treating one malignancy in the patient, but we are increasing the risk of secondary other malignancy also. Okay? So radiation is also not very harmless. Okay, it is also a harmful procedure that we do, radiotherapy. So you have to remember, bachcho, prior radiotherapy to the chest, if it is given, okay, we try to avoid the second radiation exposure. Okay? Next important is, if it is a multicentric breast cancer. What do I mean by multicentric breast cancer? For example, this is your breast tissue and it is divided into 4 quadrants, right? And if I talk about multicentric breast cancer, that means it is actually involving multiple quadrants. It is actually involving multiple quadrants. This is what is a multicentric breast cancer. Got it? So if it is a multicentric breast cancer, can we only remove one lump? No. Okay, we have to remove multiple lumps. And if you are removing multiple lumps, definitely, will there be any breast tissue left behind now? No, there won't be any breast tissue which is left behind. That is the reason if more than one quadrant is involved, bacho, it is called as multicentric, and that is the reason it's better not to go for BCS in this patient, because no breast tissue will be left behind. Then what, on the other hand, what is multifocal? Multifocal मतलब एक ही quadrant involved है, but many foci are there. ठीक है, multiple foci are there. एक ही quadrant में there are multiple lumps which are there. So again, in that condition, a lot of breast tissue has to be removed, and again it will not be useful to do a breast conservation surgery in this patient. So multicentric, multifocal breast cancers, BCS is contraindicated. Next is collagen vascular diseases. Collagen vascular diseases जो होता है बच्चों, that means conditions like SLE, rheumatoid arthritis, scleroderma, all your rheumatology diseases. Okay, so SLE, rheumatoid arthritis, scleroderma, Sjogren syndrome, all of these. In all these conditions, these collagen vascular diseases, okay, here these autoimmune conditions, we have like usually radiotherapy is contraindicated. Why? Because if we give radiotherapy to this patient, there is increase in their inflammation. Yes, the inflammatory conditions like these, they are going to definitely worsen, and the patient will have worsening of symptoms. That is the reason you have to avoid radiotherapy in the patients with collagen vascular diseases, something like SLE, rheumatoid arthritis, Sjogren syndrome, scleroderma, all of these patients. Okay? Next is LABC. If it is a locally advanced breast cancer, that we already know that breast conservation surgery is only done for an early invasive breast cancer. If it is a locally advanced breast cancer, when the cancer has spread to a lot of structures or when it is involving the lymph node, can we go for a BCS? No. So these are the contraindications that you have to be aware of. Next, bacho, if I talk about mastectomy now. Mastectomy, ectomy is removal. Mastectomy is removal of the breast, right? So you have to remember, mastectomy is nothing but the removal of breast tissue is what is called as mastectomy. Now there are various types of mastectomy that you have to remember. The first one which is there is called as a simple mastectomy. So if breast conservation surgery cannot be done in a patient due to some contraindication, we are going for the second option, and that is our simple mastectomy. Simple mastectomy, what do we remove? There are three structures that we are going to remove in a simple mastectomy. Here we will do removal of, first is definitely the breast tissue will be removed. Okay, obviously. Second, definitely you have to remember that breast tissue rests on which fascia, bacho? Breast is definitely on the pectoralis fascia. So a lot of time it happens that the pectoralis fascia is commonly involved. So here in a simple mastectomy, we also have to remove the pectoralis fascia. And third important, we are also going to remove the nipple areola complex. NAC is nothing but nipple areola complex. Okay, I'll write it over here once. Okay, so definitely nipple areola complex will also be removed. Okay, so simple mastectomy is removal of three things. First is removal of the breast tissue. Second is removal of the pectoralis fascia. Third is the removal of NAC, that is the nipple areola complex. Next is the Halstead's radical mastectomy. Now simple to dekh li. Halstead's radical mastectomy. What do I mean by radical? That means not only the breast tissue, but a lot of other structures will also be removed. Jo bhi structure aaspas involved hai, all of them will be removed. That is called as a Halstead's radical mastectomy. Why Halstead? Halstead was the surgeon who performed it first. So Halstead's radical mastectomy, bache, it is removal of what? Removal of breast tissue. Okay, it is actually removal of the breast tissue. It is removal of the pectoralis fascia. Okay, it is removal of the pectoralis fascia. It is removal of the NAC, nipple areola complex. Yahan tak to it was simple mastectomy. Plus, here we are also going to remove the pectoralis major muscle. Here we are also going to remove the pectoralis major muscle and even the pectoralis minor muscle. Here we are going to remove the pectoralis major and minor muscle. Along with that, we are also going to remove the axillary lymph node. How many levels of axillary lymph nodes do we have? Level 1, 2 and 3. Lateral, behind and medial to the pectoralis minor. So all those level 1, okay. Okay, all those level 1, 2 and 3. Okay, level 1, 2 and 3 axillary lymph nodes are also removed. Level 1, 2 and 3 axillary lymph nodes are also removed. That has to be remembered. Okay? So please remember, see kitne sare structure nikal rahe hain. We are removing the breast tissue, the pectoralis fascia, the nipple areola complex, the pectoralis major, pectoralis minor muscle and even the level 1, 2 and 3 axillary lymph node. That has to be remembered. Okay? Now if I talk about MRM, what do we thought कि यार इतने सारे structures निकालना हर patient में जरूरी है क्या? every patient of locally advanced breast cancer, does she needs removal of all these tissues? No. So let's try to save some tissue, and therefore we came up with the modified versions of your Halstead's radical mastectomy. And that modified version of Halstead's radical mastectomy, bache, here we are trying to save some tissue, and that is called as MRM, modified radical mastectomy. In the modified radical mastectomy, you have to remember what are the structures which are removed now. First, definitely we are going to remove what? We are going to remove the breast tissue. First, we are definitely going to remove the breast tissue over here as well. Second, we are going to remove the pectoralis fascia. Okay, second, we are going to remove the pectoralis fascia. Third, we are going to remove the NAC, that is nipple areola complex. Okay, nipple areola complex. Okay. And the fourth important, we are going to remove the level 1, 2 and 3 axillary lymph node. तुम बोलोगे बचा है क्या फिर? Level 1, 2 and 3 axillary lymph node. Okay. So these are the structures we are going to remove, plus minus. All right. Plus minus pectoralis minor muscle. Yes. Plus minus pectoralis minor. Why I am writing plus minus pectoralis minor? Because in one of the modified radical mastectomy, we are going to remove the pectoralis minor muscle in two of them, and in one of them we are not going to remove it. Okay? So sometimes pectoralis minor muscle will be removed in MRM, sometimes it won't be removed. Therefore I am writing plus minus. But what is never removed is the pectoralis major muscle. Pectoralis major muscle is never removed in a modified radical mastectomy. Okay? That's the important thing. Now important is you have to remember that if the pectoralis muscle is not removed, it is just retracted. That means we are just going to retract the pectoralis minor muscle. ठीक है, minor के बारे में बात चल रही है. This is pectoralis minor. If we are only going to retract the pectoralis minor, this type of MRM, बच्चों, this type of MRM is called as the Auchincloss MRM. This is what is known as the Auchincloss MRM. Okay. If you are only going to retract the pectoralis minor muscle, you are not going to cut it. That is called as Auchincloss MRM. But if you are going to cut the pectoralis minor muscle, if you are going to cut the pectoralis minor, that is either called as a scanlons. That is either called as a scanlons hota hai, or second one will be the Patty's MRM. If you are going to cut it, then it is called as a scanlons or the Patty's MRM. Okay? So please remember, modified radical mastectomy can be of three types. One, when you are only going to retract the pectoralis minor muscle, is called as Auchincloss. And when you are going to cut the pectoralis minor muscle, that is one is called as the scanlons MRM and second is called as the Patty's MRM. कोई दिक्कत नहीं बच्चे? That is the important thing you have to remember. ठीक है? Done with this? Now if I talk about the axillary clearance. ठीक है? Shall I? Axillary clearance means what? See, I've told you now, when the lymph nodes are involved, we also have to remove the lymph nodes in a case of breast cancer. Otherwise, if you remove the lymph nodes, definitely the cancer is still going to spread. Therefore, we also have to clear or we also have to remove the lymph node. That is what is called as axillary clearance or the axillary lymph node clearance. How many lymph nodes are removed in axillary clearance, bache? That has been a question. How many lymph nodes are removed? So you have to remove minimum 10 lymph nodes. Yes, minimum 10 axillary lymph nodes are removed. Minimum 10 axillary lymph nodes are removed. So when you do a axillary lymph node clearance, you have to remember minimum 10 of them will be removed. ठीक है, कम से कम 10 निकालना है तुम्हें. No issues with this anybody? Lymph nodes I am talking about. Level की बात नहीं चल रही, level 3 ही होती है. Lymph nodes, there are multiple lymph nodes. ठीक है, minimum 10 axillary lymph nodes are to be removed. Now if I talk about the complications of this axillary lymph node clearance, or if I talk about the complications of MRM as a whole, ठीक है, complications of axillary lymph node clearance or complications of MRM as a whole, definitely क्या क्या होंगे complication? First, definitely the patient can have bleeding. First, the patient can have bleeding. Any surgery or any surgical procedure can lead to excessive bleeding or hemorrhage. ठीक है, so that is common. Second, there will be flap necrosis. Now, what is a flap necrosis? See, you have created a flap. तुम्हें breast tissue निकालना था बच्चे. हाँ, all a treatment for your breast cancer itself. ठीक है, तुम्हें breast cancer निकालना था definitely. For that, what you did? You have actually created a flap of the skin and you have removed the breast tissue. Now, do you remove the skin? You remove the skin only if there is skin involvement. If there is no skin involvement, you are not going to remove the skin. Rather, you are going to create a flap of the skin. You are going to remove the breast tissue and then you are again going to place back the skin. Okay? So this flap that I have created, okay, if that flap is very thin, if that flap is very thin, will it have enough blood supply? No. And if it will not have enough blood supply, it will undergo necrosis. तो flap necrosis हो सकता है. Next important is injury to the nerves. This has been a previous year question. Injury to which nerves will be there? There will be multiple nerves बच्चे जिसको इंजरी हो सकती है. But important is the most common one which you have to remember is definitely the ICBN. Yes. Nobody thought कि definitely ये question आएगा. So please remember it is the ICBN definitely. ICBN is nothing but intercostobrachial nerve. Yeah. The most common nerve injury in a case of breast cancer is nothing but the intercostobrachial nerve. It is nothing but the intercostobrachial nerve, which is the most common nerve injury in a case of modified radical mastectomy or in a case of axillary lymph node clearance. कोई दिक्कत नहीं है इसमें. That has to be remembered. ठीक है, intercostobrachial nerve. This has been a PYQ. Now important is lymphedema can also occur. Okay, long standing lymphedema can occur. What is lymphedema? सबसे पहले edema is nothing but collection of fluid, and which fluid has collected over here? Lymph. As the lymph has collected over here, this condition is known as lymphedema. Please remember, lymphedema, we'll talk about it in vascular surgery. Lymphedema can occur in the upper limb also and in the lower limb also. But if there is lymphedema in the upper limb, uska most common cause is usually MRM itself. Okay? So can you see definitely the patient is having swelling of this hand. The patient underwent a modified radical mastectomy on this side. Can you see removal of breast has been done? Along with that, she might have undergone an axillary lymph node clearance also. Okay? And after that, after few months or few days, the patient develops such a huge swelling of the same sided arm. Okay, same side के हाथ के क्या हो जाएगा, बहुत बड़ी swelling हो जाएगी, and that is due to collection of the lymph over here. That is lymphedema बच्चे. But if there is a long standing lymphedema, if this lymphedema is not taken care of, अगर उसका ध्यान नहीं दिया जाता, what is going to happen? The patient might develop a secondary malignancy. Yes, from this lymphedema there will be a cancer of the lymphatic vessels which can arise. Okay, cancer बन जाएगा lymphatic vessels का. But कब बनेगा? Long standing, मतलब 8 से 10 साल बाद. अगर ये लिम्फेडिमा को 8 से 10 साल तक ध्यान ही नहीं दिया गया, किसी ने देखा ही नहीं इसको, then it will develop into a secondary malignancy. Okay, 8 to 10 years later, if it is not taken care of, it will lead to a secondary malignancy known as lymphangiosarcoma, and that lymphangiosarcoma is known as the Stewart-Travis syndrome. And this is a previous year question again, NEET PG. Okay, so please remember, lymphedema, when it is long standing for almost a span of 8 to 10 years, the patient is going to develop a secondary malignancy, and that secondary malignancy will be called as Stewart-Travis syndrome. Okay, remember this. I am going to ask you in lymphatics when we are studying vascular surgery. Okay, Stewart-Travis syndrome. कोई दिक्कत नहीं है इसमें. So Stewart-Travis syndrome is a secondary malignancy बच्चे which actually develops from a lymphedema. It is nothing but cancer of the lymphatic vessel known as lymphangiosarcoma. ठीक है, that's important. Previous year question है ये भी. Now, if they ask you what is the most common complication of the modified radical mastectomy, see here I have discussed about the complications of axillary lymph node clearance as well as MRM. But if they ask you specifically what is the most common complication of MRM, so you have to remember the most common complication of MRM is nothing else but seroma, and this has been a previous year question. Yeah, the most common complication of MRM is actually a seroma. Now what is a seroma? Oma is a benign tumor, but is it a benign tumor? No. It is actually a tumor-like collection of a serous fluid. As there is tumor-like collection of serous fluid, यहाँ पे ना पानी भर जाएगा, एक cavity, एक cyst बन जाएगा usually. Please remember, ठीक है? Yeah, there was a lymphedema का case, definitely elephantiasis का case था. Yes. So seroma is nothing but, please remember बच्चों, there will be a collection of serous fluid after a modified radical mastectomy in the patient. Usually it is present in the axilla. ठीक है? That is what is called a seroma. What is seroma? As I've told you, collection of serous fluid. Correction of serous fluid is what is known as a seroma. Important is, if I talk about the treatment now, what will be the treatment in a case of seroma? You have to remember, the treatment in a case of seroma should be aspiration. We will take a needle and a syringe, we are going to insert it and we are going to aspirate all the fluid which has been collected. ठीक है, निकाल देंगे उस fluid का जो पानी भरा हुआ है. And then definitely to prevent any recurrence, we are going to apply tight pressure bandage. If we do not apply a tight pressure bandage, definitely again there will be collection of fluid over there, right? So therefore, if I talk about the treatment, you have to remember treatment is nothing but aspiration followed by pressure bandage. Again a previous question, this is aspiration followed by pressure bandage. ठीक है, so that's the important thing बच्चों. Aspiration followed by pressure bandage is an important question of previous year exam. That is the treatment for your seroma. Okay. Now if I talk about sentinel lymph node biopsy, okay, if I talk about the sentinel lymph node biopsy, now what is the sentinel lymph node? सबसे पहले तो what is a sentinel lymph node? So you have to remember that sentinel lymph node is nothing but the first draining lymph node of a cancer. सबसे पहली lymph node जिसमें वो कैंसर जाके ड्रेन कर रहा हो उसको बोला जाता है sentinel lymph node. Okay, the first draining lymph node of a cancer is known as a sentinel lymph node. This sentinel lymph node biopsy was usually started for penile cancer, and that was done by a surgeon named as Cabana. Therefore, this sentinel lymph node biopsy for penile cancer is known as a Cabana's procedure as well. ठीक है? क्यों करे जाते हैं sentinel lymph node biopsy? For example, what did I tell you? If there is a cancer which spreads via the lymph to the lymph nodes, okay, there will be enlargement, there will be increase in the size of lymph node, there will be lymphadenopathy, right? Important is, when you palpate these lymph nodes, definitely you can feel if the size of the lymph nodes is increased, you can easily palpate these lymph nodes in the axilla, right? And depending on that, you can conclude or you can decide this patient is having breast cancer. Along with that, the lymph nodes are palpable. That means there is a very high chance the patient is having lymphadenopathy or lymphatic metastasis. But there will be some patients, bache, you have to remember, in which there will be some patients in which definitely the cancer spreads to the lymph nodes, but these lymph nodes are still not palpable. वो अभी तक palpable नहीं है. Okay, you are not able to palpate them properly. So in these type of patients where the patient is having a breast cancer, there is also lymphatic metastasis, but the lymph nodes are not palpable. ऐसे condition में, if you want to check whether the lymph nodes are involved or not in the breast cancer, in this condition you go for a sentinel lymph node biopsy. Got it? So now for sentinel lymph node biopsy, what is done? There are two techniques that we can use, or we can use the combination of both the techniques as well. So sentinel lymph node biopsy, first of all, what is the indication? I've told you where lymph nodes are not palpable. Sentinel lymph node सबसे पहले, what is the sentinel lymph node? First draining lymph nodes of a cancer. They are nothing but first draining lymph nodes of cancer are what are called as the sentinel lymph node. Indication is what? When the lymph nodes are not palpable. When the lymph node are not palpable, you have to go for a sentinel lymph node biopsy to see whether they are involved or not. The techniques which are used, the first one which is there, bacho, it is known as the blue dye technique. Now by the name it is evident we are using some kind of a blue dye. Okay, and how are we going to perform this technique? See, now we are going to take a blue dye. Either it can be a methylene blue or it can be a isosulfan blue, and then we are going to inject this dye. See, we are going to inject this dye around the areola of this patient, around the nipple and the areola. We are going to inject this dye around the nipple or the areola of this patient. This is called as periareolar injection. Okay? And then definitely this dye will go to the breast cancer. From the breast cancer, this dye will be going to what? It will be going to the lymph nodes also. Okay, from the breast cancer, this dye will also go inside the from this breast cancer, you have to remember the dye can also go inside the lymph node, and the first lymph node in which it will drain is called as a sentinel lymph node. So definitely during surgery, when you open it, definitely you can see the blue dye in the lymph node, and the lymph node which will be there, it will change its color. The lymph node will going to become blue due to all that dye going inside the lymph node. These lymph nodes are going to become blue. So definitely all those lymph nodes which are blue in color, bache, definitely these are the lymph nodes which are receiving the lymph from the cancer directly, and therefore these lymph nodes are to be removed. These lymph nodes are to be removed, jitne bhi hai. Okay? So that is what is important. So this is going to help us in actually removing all the lymph nodes which are involved in the cancer, even if they are not palpable. That is the blue dye technique. Second technique jo hai bache, that is called as a radionucleotide technique. In that radionucleotide technique, actually we inject a radioactive substance. Radioactive substance, something like technetium 99. Okay, we are going to inject a technetium 99 tagged sulfur colloid, and that technetium 99 tagged sulfur colloid, when we inject, it is again going to go to the cancer. From cancer again it will go to the lymph nodes, and then we will take a gamma camera, and with the help of that gamma camera we are actually going to detect, okay, where we are actually finding this radioactive substance. Wherever there will be this radioactive substance, the machine is going to beep out. So जहाँ जहाँ beep करेगी, that means definitely these lymph nodes have been involved. ठीक है? So that is important. You can just remember, तुम्हें कोई procedure नहीं पूछने वाला. You just have to remember बच्चे that what are the methods that we use definitely for a sentinel lymph node biopsy. The first one, as I've told you, it is the blue dye technique. Blue dye technique में the dyes which are used, blue dye technique में the dyes which are used, you have to remember, it is one is definitely called as the methylene blue dye. One is definitely the methylene blue dye. and second is definitely the isosulfan blue. Second is definitely the isosulfan blue dye. ठीक है. Next important which is there बच्चों, you have to remember it is the radionucleotide technique. Second is definitely called as the radionucleotide technique. And in this radionucleotide technique, what is the dye or what is the contrast used? नाम पता होना चाहिए बस. The contrast of the dye which is used in the radionucleotide technique, the radioactive substance, it is actually a technetium-99. It is a technetium-99 tagged sulfur colloid. Technetium-99 tagged sulfur colloid which is used in the patient. ठीक है. So that has to be remembered. That is more important to be remembered. And कौन सा कैमरा यूज किया जाता है? Definitely we are going to use a gamma camera. We are going to use a gamma camera. Gamma ही है. ठीक है. What is the best technique? That has been a previous year question. What is the best technique? Definitely that was a previous year question, you have to remember. So the best technique for sentinel lymph node biopsy is actually combination of both. Yes, best technique for sentinel lymph node biopsy is combination of both A plus B. It is combination of both A plus B, that is the blue dye technique as well as the radionucleotide technique. दोनों का combination मिला के is the best technique for your sentinel lymph node biopsy, and this has been a previous year question as well. ठीक है. No issues with this anybody बच्चों? That is important to be remembered. ठीक है. चलो. Once you are done with this, now let's talk about the breast reconstruction surgery. Now definitely if you have removed the breast of a patient and if she wants the breast to get reconstructed, उसको वापस से reconstruct करनी है breast definitely. If she is in the younger age group, okay, definitely you can reconstruct a breast. And for that breast reconstruction surgery, you have to use some flap, right? We can definitely use the silicone gel implants, but apart from silicone gel implants, we can also use a flap because not all patients just want the silicone gel implants. Some people actually want a real breast itself. So for that, we can use flaps. The question has come on the flaps. Which are the best flap? Which is the most commonly used flap? ठीक है, तो वो question आता है. So you have to remember, if I talk about the breast reconstruction surgery, the best flap which is used, can you see over here? ये जो दिख रहा है, okay, this type of incision, ये ऐसी images पहले आ चुकी एग्जाम में, okay, they have asked which type of flap is used in this patient for breast reconstruction. Can you see there is a suture mark over here? Yes, the suture mark is on the abdomen of this patient. That means there is actually a flap which has been taken from the abdomen of this patient, and then with the help of that, the breast have been reconstructed. This is the best type of flap, bachcho. It is known as the DIEP flap. The best flap which is used is known as the DIEP flap. And what is the DIEP flap? Let's write it down. This DIEP flap is the best kind of a flap, and this DIEP flap is deep inferior epigastric artery perforator flap. Yes. What is the name? It is nothing but deep inferior epigastric artery perforator flap. Okay. So please remember, it is the deep inferior epigastric artery perforator flap. That is what is the DIEP flap. At least remember the name DIEP. That's more important. Okay. Now second important, if they ask you which is the most commonly used flap, so you have to remember the best flap is definitely DIEP, but here the surgery is time taking, the surgery is thoda bahut risky. Therefore the most commonly used flap which is there, it is not that one. Most commonly used flap is actually your tram flap. What is the tram flap now? Tram is nothing but transverse rectus abdominis myocutaneous flap. Yes. So what is tram? Definitely you have to remember, tram is nothing but transverse rectus abdominis. It is transverse rectus abdominis myocutaneous flap. Transverse rectus abdominis myocutaneous flap, bache, is the most common type of flap that we use for breast reconstruction surgery. Okay, that we use for breast reconstruction. And the third type of flap which is there, it is shown in this image. Can you see? Here the patient's breast have been reconstructed, but the flap was taken from here. Okay, markings have been done na yahan pe. So the flap has been taken from here. Which muscle is over here? That is the latissimus dorsi muscle. So definitely it is called as the LD flap. What is LD flap? Latissimus dorsi flap. So we can even take a LD flap, that is the latissimus dorsi flap, bachcho. Okay? So that has to be remembered. Please remember, these are the three types of flap which can be used for breast reconstruction surgery. Done with this anybody? Everybody? Sorry. Okay, this is the important thing that you have to be aware of. Okay? No issues with this anybody? Now I'll just talk about, as we are talking about treatment itself, I'll just add on a point. Just a minute. I actually want a slide. Just a minute. I have to add a slide. Chalo, I'll write it somewhere here itself. You can just add a slide in your notes, or you can just write it somewhere. Okay. I'll write the important things that we have. LD is latissimus dorsi. Latissimus dorsi. Muscle latissimus dorsi. Okay. It is the latissimus dorsi flap. So here I'll write bacho. Okay. There are two things definitely. That we have to write down, which are not in the this one. First is chemotherapy, which is given. So first, before chemotherapy, I'll start with breast cancer in pregnancy. How breast cancer in pregnancy is managed? This has been a previous year question, and a lot of people make mistakes in that. I don't want you to make mistakes in that, so please remember. They always say that the patient has been diagnosed with breast cancer in pregnancy. What is the management now? Okay? So if I talk about breast cancer in pregnancy, bache, so the first one, if the patient is diagnosed with the early invasive breast cancer in pregnancy, if the patient is diagnosed with the early invasive breast cancer in pregnancy, then you have to remember, if the patient is diagnosed with the early invasive breast cancer in pregnancy in the second or the third trimester, if she is diagnosed in the second or the third trimester, then definitely we have to go for a BCS. Yes, we can do a BCS in this patient. Yes, if she is diagnosed only in the second or the third trimester, we can go for a BCS, that is breast conservation surgery. But can we give radiotherapy during pregnancy? No. So in that condition, you have to remember one thing, that radiotherapy will be given after delivery. Yes, radiotherapy can be given after delivery, because as she is diagnosed with the cancer in second or third trimester now, therefore we can perform the surgery in the second or the third trimester, but we will give radiotherapy after delivery itself. Okay? So breast conservation surgery, but radiotherapy after delivery. But radiotherapy after delivery can be given. Okay? So that can be the treatment which we can use. Or if you think that she has been diagnosed with the early invasive breast cancer in the first trimester itself, tab to BCS cannot be done. Okay? Or if she has been diagnosed with breast cancer in early invasive breast cancer, definitely in the second or third trimester, but you still feel that it's risky to go for a BCS in this patient, or the patient herself does not want a BCS. वो बोल रही नहीं फालतू में मुझे रिस्क नहीं चाहिए कोई भी. So in that patient it's better to go for a simple mastectomy. Okay? In that patient it is better to go for a simple mastectomy. Patient will have another breast to feed the child, and if the child is having any deficiency, the child can be fed by formula milk as well. Okay? So that can be done, cow milk or formula milk as well. No issues with this, anybody? That is important. Next important, if I talk about the patient, if she is diagnosed with a locally advanced breast cancer during pregnancy. If she is diagnosed with a locally advanced breast cancer during pregnancy, you have to remember, if a patient is diagnosed with locally advanced breast cancer during pregnancy, what is the management of this patient? What is the normal management for LABC? It is neoadjuvant chemotherapy, followed by MRM, followed by radiotherapy. So what are we going to do over here? Here you have to remember, bache, we have to give neoadjuvant chemotherapy to the patient. But in which trimester? In the second or the third trimester. Yes, we can give chemotherapy to the patient, but only in the second or third trimester. Why? Because in first trimester, we cannot give chemotherapy to the patient. We cannot give any anti-cancer drug to the patient, because in first trimester, there is organogenesis which is happening. And all these anti-cancer drugs are teratogenic. They are going to damage the fetus. Therefore, we have to avoid all of them in the first trimester of pregnancy. But we can give them in the second or third trimester. Once they are given in the second or third trimester, then definitely we are going to go for a MRM. Okay, during pregnancy only we can go for MRM, modified radical mastectomy. But the radiotherapy which is there given, it will be given after delivery. Yes, here also radiotherapy is given, but it is given after delivery. No issues with this. Here also radiotherapy will be given, but after delivery itself. Got it? So this is important. You have to remember that which management techniques are not at all used in pregnancy, or which are absolutely contraindicated during pregnancy. So one thing is hormonal therapy, and second is radiotherapy. Hormonal therapy and radiotherapy are absolutely contraindicated during pregnancy. Okay, during all trimesters of pregnancy, I'll rather say. So please remember, hormonal therapy and radiotherapy are contraindicated during all trimesters of pregnancy. NACT is neoadjuvant chemotherapy. Neoadjuvant chemotherapy. Okay. So hormonal therapy and radiotherapy बच्चे, it is contraindicated during all the trimester. HT and RT is hormonal and radiotherapy. ठीक है, तो please remember hormonal and radiotherapy are contraindicated during all the trimesters. But chemotherapy अगर वो पूछे, so you have to remember chemotherapy is only contraindicated during the first trimester. We can give it in the second or third trimester, right? We have seen that. So usually chemotherapy is contraindicated only during the first trimester. We can give it in the second or third trimester. Got it? So chemotherapy is only contraindicated during the first trimester. That is a very important fact that you have to remember. That you have to remember about breast cancer management during pregnancy. Okay? So this is important and a commonly repeated question of exams. Okay, and last, if I talk about the chemotherapy which is given during pregnancy, chemotherapy which is given in a patient of breast cancer. Okay, the chemotherapy which is given in a patient of breast cancer, I'll write over here. Okay, I've said now, HER2 new positive breast cancer, usually in these conditions, definitely we can give chemotherapy to the patient. Just a minute, let me check if there is any site to write it. No, it's better you can write it over here, or anywhere you get a space, or you can add a page over there, a small sticky note you can add. So chemotherapy, definitely if I talk about bachcho, the chemotherapy which is most expected, HER2 new का मतलब होता है बच्चे, HER2 new are the receptors which are present on the breast cancer cells. Okay, याद रख लो definitely, if the HER2 new receptors are present on the breast cancer cells, definitely these are going to, the HER2 new factor will come and stimulate these receptors, and therefore there will be more proliferation of the breast cancer cells, and the size of the breast cancer is going to increase. Okay, therefore if we want that the size of the breast cancer to decrease, we have to block these HER2 or the new receptor. HER is nothing but the human epidermal growth factor that you have to block. Okay, so that is the important thing. So chemotherapy is given in which all conditions? We know chemotherapy is definitely required if the lymph nodes are positive. Indications of chemotherapy I am writing. If the lymph nodes are positive, or if it is a LABC, that is a locally advanced breast cancer. Okay, it can be even given in a patient of sorry, it can be even given in a patient who is having a HER2 new positive breast cancer. Okay, HER2 new positive breast cancer. It is even given in a patients who are having ER and PR negative breast cancer. ER, PR negative breast cancer. These are the indications of chemotherapy. In these patients, we have to give chemotherapy. Okay, simple mastectomy is done in the first trimester, sir. It can be done in the first, second, or third trimester. कभी भी कर सकते हो, because it does not require any kind of radiotherapy. ठीक है? Important is बच्चों definitely. What is the cycles for chemotherapy that is given? So you have to remember, it is usually chemotherapy के लिए we have to give 4 cycles of AC. We have to give 4 cycles of AC. What is AC now? 4 cycles of A for adriamycin, and C for cyclophosphamide. Okay, we have to give 4 cycles of AC, that is 4 cycles of adriamycin and cyclophosphamide, followed by, उसके बाद क्या करेंगे? Followed by definitely, followed by 4 cycles of paclitaxel. Just a minute. Followed by 4 cycles of paclitaxel. Okay, it is another anti-cancer drug. Okay, so you have to remember the chemotherapy regime which is commonly followed for breast cancer nowadays. It is 4 cycles of AC, that is adriamycin and cyclophosphamide, followed by 4 cycles of paclitaxel. You can remember the mnemonic ACP. Okay, so 4 cycles of AC and 4 cycles of P. No issues with this, anybody, bacho? That is what is the chemotherapy followed in a treatment of breast cancer. Done with this? Shall I move further? Okay, so let's move further now. Talking about the distant metastasis from a breast cancer. Sorry. Now, if I talk about distant metastasis from a breast cancer, bacho, 5-fluorouracil can be used, but the most commonly used treatment regime which is there, bache, it is ACP. Okay? ACP, that is 4 cycles of adriamycin and cyclophosphamide is given, and followed by that 4 cycles of paclitaxel are given usually. Okay? That is nothing but the chemotherapy regime which is given in the patient of breast cancer. Okay? That you have to remember. Now if I talk about the distant metastasis, as I've already told you, that means spread or metastasis to the distant organs, to the other organs as well. Distant metastasis Please remember the investigation of choice. I have already told you for distant metastasis in most of the cancers of the body, it is always PET scan, positron emission tomography. The contrast that is used is 18 FDG fluorodeoxyglucose. Half life is 110 minutes. Distant metastasis का most common site. Okay, सबसे पहले तो important is, I hope all of you are quite aware from this about this from pathology, that there are three sites or three ways of spread of a cancer. There are three ways of metastasis. One, it can occur by direct invasion. Yes, if the cancer directly spreads into the adjacent tissues, that is called as direct invasion. Second, if it spreads by the blood route, that is hematogenous route. And third, if it spreads by the lymphatic route. Third, if it can spread by the lymph node or lymphatic channel or via the lymphatic route. Okay? These are the three ways. Definitely you have to remember that. Next important is you have to remember that the most common site which is there, bacho, the most common site which is there. Please remember the most common site for distant metastasis will be the bones. In a breast cancer, the most common site of distant metastasis are the bones. And how does the cancer spread to the bones? So the cancer, breast cancer spreads to the bones via the hematogenous route, via the blood route. It cannot spread to the bones via lymphatic route, na? So it spreads to the bones via the hematogenous or via the, sorry. It spreads to the bones, bache. It spreads to the bone definitely via the hematogenous route. Now important is which are the most common bones involved. So you have to remember in the bones, the most common bone involved is nothing but the spine. Yes, the vertebra. The most common bone involved are nothing but the spine or the vertebra. In spine, which is the most common bone involved or most common vertebrae involved? In the spine, the most common vertebra involved are the lumbar vertebrae followed by the thoracic vertebrae. In spine, most common vertebrae involved are actually the lumbar vertebrae followed by the thoracic vertebrae. And definitely when a cancer spreads to the bones, it is going to destroy the bone or form the bone. It is mainly, majority of the times, if a cancer spreads to the bone, if a cancer involves a bone, it is going to destroy a bone. And if it is going to destroy a bone, definitely, you have to remember this type of metastasis, which is causing breakdown of a bone, is called as osteolytic metastasis. But if the cancer forms the bone, it is called as osteoblastic metastasis. Yaad rakhna, most of the cancers in the body, when they spread to a bone, they are going to destroy the bone, causing osteolytic metastasis. Breast is a cancer which can show both. Breast cancer can show osteolytic as well as osteoblastic metastasis. But more commonly it shows what? Just like all other cancers, it will show more commonly osteolytic metastasis itself, bone breaking. Okay, more commonly it shows osteolytic, but you have to remember other cancers cannot show osteoblastic. This is a cancer which can also show osteoblastic metastasis. More commonly it shows osteolytic metastasis. And definitely on this, can you see? Just a minute. On this MRI, can you see definitely there is destruction of this vertebra over here. This lumbar vertebra has been destroyed over here. So this is the metastatic breast cancer where the metastasis is actually destroying the bone. And as I've told you, via hematogenous route, but via which veins? Definitely that you have to remember, via a special group of veins which does not have the valves. As these are valveless veins, they do not contain any valves, therefore the spread of cancer is easy via these veins, and that is known as the Battison's plexus of veins. Okay, that is known as the Battison's plexus of veins. Okay, so please remember the common drainage site for your lumbar vertebra and for your breast can be this Battison's plexus of veins, and via this Battison's plexus of veins it can spread to the lumbar vertebra commonly. It can spread to the lumbar vertebra. Important is, can anybody tell me everything remains same? The most common route of spread, hematogenous, via the Battison's plexus of veins. Most common site, bones. Where? Spine. Exactly where? Lumbar vertebra followed by thoracic vertebra. But only one thing changes. That is, more commonly it will cause osteoblastic metastasis, bone forming. What is that cancer? What is that cancer which is going to cause all of this, but more commonly osteoblastic metastasis? Everything remains same. कौन सा cancer है वो बच्चों? Anybody? It is also a hormonal cancer. Very good. It is a prostate cancer in males. Very good. It is a prostate cancer in males where everything remains same. Only the metastasis which will be there, it will be more commonly osteoblastic metastasis. Shabash, shabash. All of you. Great, great. No issues with this, anybody? Chalo. Now let's discuss further about the next conditions of your breast. The first one being your Paget's disease of the nipple. If I talk about the Paget's disease of the nipple now, as I've discussed already that Paget's disease is also seen in bones, but this is a different one. Paget's disease of nipple is nothing but a superficial manifestation of an underlying malignancy. इस term का मतलब क्या? Patient में कहीं ना कहीं तो breast cancer है, वो शायद तुम्हें feel नहीं हो पा रहा, patient को कोई symptom नहीं आ रहे, but patient को बाहर क्या दिख रहा है? Paget's disease of nipple दिख रहा है. That means अगर patient में बाहर Paget's disease of nipple है, मतलब वो definitely breast cancer है. If the patient is having Paget's disease of nipple, that is sure shot confirmation of a underlying malignancy. Though the patient has symptoms or not has the symptoms, you have to check for breast cancer in that patient. Okay? So please remember, Paget's disease of nipple is a superficial manifestation of an underlying malignancy. It will only happen if the patient has a cancer, underlying cancer. Okay? Next important condition you have to remember, it is actually a unilateral condition. It is actually a unilateral condition. Why this is important statement? Because eczema of the nipple, it is a bilateral condition. But this is not eczema. This is not only dryness of the nipple. This is rather eczema-like condition where there will be dryness of the nipple, where there will be crackling, rather destruction of the nipple areola complex. Okay? So that is important, you have to remember. Please remember, unilateral eczema-like condition. It is a unilateral eczema-like condition of the nipple which is going to cause destruction of the nipple areola complex. Which is going to cause destruction of the nipple areola complex. As you can see over here in this picture, can you see the nipple areola complex has been completely destroyed in the patient. Okay, important, which are the common malignancies associated with Paget's disease of nipple? The common malignancies which are associated with it is either a DCIS. What is DCIS? Ductal carcinoma in situ, or a IDC, that is an invasive carcinoma, invasive ductal carcinoma. It can be an invasive ductal carcinoma. These are commonly associated or commonly the underlying malignancies seen in a patient of Paget's disease of nipple usually. Yes, CEA positivity can definitely help you to differentiate it from eczema. Okay? Next important is, what is the diagnosis के लिए, what do we need to do for diagnosis? Definitely, as there is destruction or as there is actually a condition involving the nipple areola complex, it's better to take a biopsy from there itself. So we actually take a biopsy from there. We take a punch biopsy. Okay, we have to take a punch biopsy from the nipple areola complex, and once we take the punch biopsy from the nipple areola complex, bachcho, you have to remember, on that punch biopsy I'll be able to see the classical Paget cells, and that is the reason why it is called as Paget's disease of nipple. I'll be able to see the classical Paget cells. So just remember, in the epidermis I am able to see the classical Paget cells. That is what is the classical feature of Paget's disease of nipple. Just remember this. Okay? Treatment की अगर मैं बात करूँ, what has to be done for treatment? You have to remember, treatment के लिए I have to treat the underlying malignancy. Treat the underlying malignancy. Okay? Actually, according to the cancer or according to the malignancy which is there in the patient, definitely we have to do the treatment. We have to treat the underlying malignancy. No issues with this, anybody? That is important treatment. Okay? No issues with this, anybody? We cannot decide the treatment. We cannot decide the treatment a simple mastectomy always. Please remember this. Okay, not always a simple mastectomy. Reason is because it can be an invasive ductal carcinoma. It can be a locally advanced breast cancer also at times. Yeah, though it is not palpable, it can be locally advanced breast cancer. Okay? That is the reason why we have to decide the management according to the staging, not directly simple mastectomy always. Okay? So that's the important thing. Okay, so that's the important thing that you have to remember, bachcho. That is about the Paget's disease of the nipple. Second, if I talk about the phyllodes tumor. Phyllodes tumor now. What is phyllodes tumor? Phyllodes tumor का दूसरा नाम है, it is also called as cystosarcoma phylloids. ठीक है? It is also known as cystosarcoma phylloids. Okay? Cystosarcoma क्यों बोला जाता है? Cysto, that means a sac-like. Okay, sarcoma, that means actually a tumor or a cancer which arises from the mesenchymal tissue. It is not a tumor which arises from the epithelium. It is a cancer or a tumor which arises from the mesenchymal tissue, or the connective tissue. Therefore, it is called as sarcoma. So it is known as a cystosarcoma phylloid. You have to remember, this is the largest type of a breast tumor. अगर breast tumor बहुत बड़ा है, the largest type of a breast tumor, it has to be a phyllodes tumor or a cystosarcoma phylloids, because all other breast tumor cannot be giant or huge. Only giant or a huge breast tumor is phylloids. So phylloids tumor or a cystosarcoma phylloids, you have to remember, though it is a very huge breast tumor, as you can see in the picture, can you see this is such a huge breast tumor, but important is majority of the cases of cystosarcoma phylloids are benign in nature. Yeah, you have to remember, majority of the cases which are there, they are actually benign in nature. No issues with this. Majority of the cases are benign in nature because the cancer, the tumor which is there, it does not even invade the pectoralis fascia. The tumor which is there, it is very huge in size, but it does not invade the pectoralis fascia. इसके नीचे नहीं जाता. It does not invade the pectoralis fascia. That is the reason in most of the cases we will not even require any radical surgery. We will just require a wide local excision or a simple mastectomy. Got it? So that's the important thing you have to remember. So majority of the cases, as I've told you, bacho, they will be malignant. Which is the age group in which it is common? So you have to remember the cystosarcoma phylloids or the phylloids tumor is more common in the third or the fourth decade of life. It is more common in the third or the fourth decade of life. Okay, it is more common in the third or fourth decade of life. What is the clinical features of the patient? The clinical feature of the patient will be, the patient will have huge, so definitely the patient will have a rapidly growing breast mass. The patient is going to have a rapidly growing breast mass, and the patient can even have skin color changes. And why are these skin color changes seen? Can you see? The skin color has changed in the patient. Okay, the skin over the breast has changed its color. Reason is, this is such a huge breast tumor, bache, that it causes compression of the blood vessels supplying the skin. As it causes compression of the blood vessels supplying the skin, there is decreased blood supply to the skin over the breast, and as there is decreased blood supply to the skin over the breast, there is ischemia, and due to that there will be necrosis. So it is actually due to the pressure necrosis from the tumor. Okay? So please remember, the skin color changes which are seen in cystosarcoma phylloids, it is due to pressure necrosis. It is actually due to pressure necrosis. कोई दिक्कत नहीं है इसमें. That's important. Now what is done for diagnosis? You have to remember, for diagnosis again we have to do a biopsy itself. Okay, for diagnosis again we can go for a true cut biopsy, and on that biopsy definitely what will be seen? On the true cut biopsy definitely what is going to be seen? Okay, on the true cut biopsy we have to see a classical feature. And what is that classical feature? We can see a leaf like appearance of the cells. Okay, we can see the classical leaf like appearance of a cell. Just a minute. Okay, we can see a classical leaf like appearance of the cell, bacho, and this is what is called as a cystosarcoma phylloids. Okay, this is the classical leaf like appearance of the cell which will be seen, and this is what is cystosarcoma phylloids. Okay, so on true cut biopsy, please remember, it is the leaf like appearance. It is the leaf like appearance which will be seen. Okay, that's the important thing. No issues with this, anybody? Next important is, you have to remember that what is done for the treatment. For the treatment, you have to remember, as I've told you, this tumor, it is mostly benign in nature. It will not involve any kind of lymph node. Second important, it is not going to invade the pectoralis fascia. Third important, it is not even involving the skin. Skin ka pressure necrosis hota hai, but it is due to blockage of the blood vessel, not due to involvement of skin. So skin involvement is also not there. So definitely in this condition, can you only remove the tumor itself? Yes. And that is what is called as wide local excision. Okay? So please remember, the treatment usually for this tumor is nothing else but wide local excision with normal margins. 2 cm के normal margins लिए जाते हैं बच्चे, and we have to perform a wide local excision. Important is, but in certain conditions, we cannot only go for a wide local excision. We also have to remove what? We also have to remove the whole breast tissue, the pectoralis fascia, as well as the nipple areola complex. So that is called a simple mastectomy. In which conditions we have to go for a simple mastectomy? There are certain indications for that. For example, if it is a case of a recurrent tumor. Yes, if it is a case of a recurrent phylloid tumor. Second, if it is a large phylloid tumor, very huge, as you can see in the picture. Okay, can you see on this CT as well? There's a huge phylloid tumor. So such type of huge phylloid tumor or large phylloid tumor. And third, if it is a case of malignancy. Okay, as I've told you, 10% cases of phylloids can be malignant as well. So definitely in these conditions, where there is recurrence, where there is a large tumor or a malignancy, in that conditions you can go for a simple mastectomy. In that conditions you can even go for a simple mastectomy. No issues with this, anybody? That has to be remembered. Okay, that has to be remembered. Otherwise, wide local excision is the primary treatment for this condition. Okay. Now let's talk about the next, and that is a benign tumor of your breast, that is known as fibroadenoma. I hope all of you are quite aware of fibroadenoma, what it is. So if I talk about fibroadenoma of breast, bachcho, please remember, सबसे पहले तो oma. Oma means it is definitely a benign tumor. Adenoma, that means a benign tumor which arises from the columnar epithelium. We know in breast there is secretion of milk, and wherever there is secretion, we should have a columnar epithelium only. Okay? So definitely it is a benign tumor arising from the columnar epithelium of the breast, and also there will be a lot of fibrous tissue inside it in this tumor. Therefore, it is called as fibroadenoma. Important is this fibroadenoma of breast is the most common cause of breast lump. For example, if a patient comes to you with a complaint of breast lump, the first thing that you have to rule out is a fibroadenoma breast, because the most common cause of breast lump usually will be fibroadenoma itself. Next important, if I talk about, you have to remember it is the most common benign tumor of breast as well. Yes, if I talk about the benign tumors of breast, the most common one which is going to happen in the patient or occur in the patient is always a fibroadenoma breast itself. If I talk about the age group which is commonly involved, you have to remember fibroadenoma breast is more common in the younger age group. It is more commonly seen in the younger patient, young females. Okay, that is usually the adolescent or young females, that is 15 to 25 years of age group. It is very common in the females between 15 to 25 years of age group. Okay, it is very common in patients between 15 to 25 years of age group. Important is, if I talk about the clinical features, what will be a clinical feature? First of all, the patient will have a firm lump. Okay, lump is obviously there because it is a tumor. Definitely it is going to form a lump. But this lump which will be there, it will not be soft. Okay, it will be a firm lump because it contains a lot of fibrous tissue. तो थोड़ा सा पूरी तरह से hard भी नहीं होगा, but थोड़ा firm होगा. There will be a firm breast lump, but it will be mobile. Okay, that means it does not stand at one place. You can move it easily. Okay, you can move that breast lump easily. That means it is a mobile breast lump. Will it be painful or painless? But it is usually painless. Okay, it is usually painless. So you have to remember here the patient is going to have a firm and a mobile breast lump. The patient is going to have a firm and a mobile breast lump. Okay, that is important. And as it is a mobile breast lump, as you can move it here and there, therefore it is also known as a breast mouse. Therefore fibroadenoma is also known as breast mouse. The reason being because you can move the fibroadenoma from here and there. It is also known as a breast mouse. Okay? Next important is it is mainly painless. It is not a painful swelling or not a painful lump. It is actually a painless lump. Okay? That is important. Now what is done for diagnosis? If I talk about the diagnosis, bache, then definitely for diagnosis, what we have to do? As I've told you, this is a young female who is coming to me with a breast lump. Definitely triple assessment should be done for a breast lump. Yes, I've started the triple assessment. I've done history taking in the patient. Okay, I've done history taking in the patient. Then definitely I've done a clinical examination. Okay, then I'll do a clinical examination. On clinical examination, after that, I will send the patient for a radiological investigation. The radiological investigation which is there, you have to remember, it is actually an ultrasound. Reason is this patient is too young. Therefore, the radiological investigation that I want to do is definitely an ultrasound. So definitely I'll send the patient for an ultrasound. And on an ultrasound, the radiologist will give me a BIRAD score. And the radiologist will clearly write it is BIRADS 2. That is benign tumor. Yes, the radiologist will clearly write it is benign tumor, that is BIRADS 2. If the radiologist writes it's benign, it is BIRADS 2, will I go for further any management? No. So yaad rakh lo, FNSC or true cut biopsy is most of the times not required for diagnosis in a patient of fibroadenoma, because radiologist khud bol raha hai it is 100% benign. That is the reason usually FNSC or biopsy is only required if the radiologist is suspicious and if he gives it as a score of BIRADS 3 or a BIRADS 4. तभी हम कर सकते हैं. Otherwise अगर वो sure shot बोल रहा है if it is BIRADS 2, then we don't have to go for anything else except the ultrasound. ठीक है? Therefore FNSC and biopsy will not be the first line choice. It is only ultrasound which will be considered as the investigation. ठीक है? That's important. Next important you have to remember बच्चे, what is done for treatment. As it is a benign tumor definitely. उसके पहले एक बार याद रख लेना. Okay, as I've told you, definitely the patient, we will only do an ultrasound. Okay, no FNSC or biopsy is required as such. Only if the radiologist is suspicious, then definitely, or you are suspicious it can be a cancer, then you can go for FNSC or biopsy to confirm or to differentiate whether it is only a benign tumor or a cancer as well. Treatment की अगर मैं बात करूँ, it is nothing but, as it is a case of a benign tumor, it is nothing else but follow up and observation. Okay, sorry, observation and follow up लिख लो. So it is nothing else but observation and follow up. You have to observe the patient, okay, and a close follow up should be done. Okay, so if it is a BIRADS 2, annual screening should be done. हर साल में बोला, If it is a virus 3, then call for a short interval follow-up, that is after every 6 months. Okay? Important is, what are the indications of surgery? When we want to operate a fibroadenoma of breast, we will only operate a fibroadenoma of breast when there are these indications. The most common indication has been asked in your examination, and that is cosmetic. Because the patient feels that it does not look good. Okay, only the patient wants to get it operated. That is the most common indication. Most of the times it is that. Patient को अच्छा नहीं लग रहा बस. Most common is actually cosmetic indication. Other can be, what did I tell you? That fibroadenomas are mainly painless. But if it becomes painful, that is suggestive that it might be converting into a malignancy. Therefore, it can be a risk factor, so better is to remove that. Next, if there is rapid increase in size, all benign tumors like fibroadenoma will slowly grow in size. But if it is rapidly increasing in size, again that is a hint that it can be a malignant conversion. It can be converting into a malignancy. So again that is the indication of removal. Family history of breast cancer. If a female is having a family history of breast cancer, उसकी माँ या बहन में breast cancer था, and she is having a breast tumor, whether it is a fibroadenoma, the risk of breast cancer will be very, very high. So better is to get it operated. And if there is a giant fibroadenoma, giant means more than 5 centimeters in size. Giant fibroadenoma means the tumor which is more than 5 centimeters in size usually. These are the indication. Once you have removed the fibroadenoma, you can confirm whether it is a benign or a malignant tumor, because otherwise the treatment will differ. So, radiotherapy देनी है या नहीं देनी, that will be different. Okay. So definitely, if you do a histopathological examination of this tumor, once you have removed that, on that you will be able to see such a classical feature. What are these? These are nothing but your glands. Can you see the glandular tissue which is there, bache? The glandular tissue is usually compressed. Why the glands are usually compressed? These glandular tissues are compressed because there is a lot of fibrous tissue. There is a lot of fibrous tissue which is there, and due to this excess of fibrous trauma, the glandular tissues are compressed. And does it look like a horn of a reindeer? ठीक है, reindeer के definitely horns के जैसा लगता है ना. Therefore, this is classically known as the antler sign. This is classically known as the antler sign. Please remember, this is the classical antral sign which is seen in a patient of fibroadenoma breast. Okay? This is usually seen on a histopathological examination when after removal of the tumor, you have sent it for a diagnosis. And lastly, it is this. This is nothing but a mammography. Usually we don't perform mammography in younger females, but if we do in a patient of fibroadenoma, we are going to see macro calcification. Why? Because fibroadenoma, we know already it is a benign tumor, and benign tumors are characterized by macro calcifications on the mammography. बंद हो गया।